Good morning, everybody. If you will, we'll call our meeting to order and go ahead and get started. We're going to have a full schedule this morning, and our goal is to finish our meeting and be through by noon because we've got some other meetings planned after that. So welcome. We're glad to have you here. And before we get started, we've got some special guests with us in the audience out here that we want to recognize, and then we're going to introduce the committee, and then we'll move right into our program. We've got Chairman Darlene Taylor is with us right here, Representative Joe Campbell over here, Chairman Richard Smith, Senator Freddie Powers Sims is here somewhere. I saw her this morning. There you are back there. Thank you. Thank you all for being here. It's good to be with you in Albany. I want to thank our friends at Albany Tech for what they have done to make it possible for us to meet here this morning. And I'm going to have to get some help to get in and out of here with all these buildings and everything. I rode around 5-10 minutes just trying to find my way in and out of here. This is quite a complex. And to Matt Trice from Albany Tech, thank you for your help with hosting this for us this morning. We appreciate that. I'm going to start just over here on my right and let the members of the committee introduce themselves and say a word, and then I'll have a few comments and we'll move right into our agenda. So,
my name is Scott Raines. I am the President and CEO of Southeast Georgia Health System. Been in the state for just over a couple of years. Prior to that, Pensacola, Florida, with Baptist Healthcare. Prior to that, Nashville, Tennessee. It's an honor to be here, and appreciate you guys being here as well.
Good morning, Valerie Montgomery Rice, President and CEO of Morehouse School of Medicine, Georgia native. Happy to see us doing this great work that's going to improve the lives of our citizens.
Representative Mike Cameron. I represent the 1st District in Northwest Georgia, most of Walker and Olive Dade. I come from a background of health insurance with Blue Cross in Chattanooga for 32 years, so I bring that to the table. Thank you.
Good morning, everyone. I'm Representative Sharon Cooper. It's House District 35. It's East Cobb and just outside of Atlanta. I chair the Health Committee, the Public Health Committee, and I am a master's level nurse, and my husband was a physician. So glad to be here. Thank you for having us.
This is Representative Mark Newton. I represent Columbia County and Augusta area, including parts of the Medical College of Georgia campus. Trained so many doctors. That's where I went to school, and I'm an ER doctor. I'm glad to be on this committee and glad to be in Albany today. Thank you.
Good morning. I'm Lisa Hagan. I'm representative for House District 156 in South Georgia, which is all of Toombs, Montgomery, and Wheeler counties, and part of Tattnall, Telfair, and Ben Hill counties. Very happy to be here today to hear these presentations. Thank you.
And good morning, Cheryl Bluestein, Vice President of Operations at Emory Healthcare. I've been with them for 16 years and have completed numerous Certificate of Need applications. So I look forward to and happy to be a part of the committee. Thank you.
Good morning. Good morning. I'm James Beverly. I am the minority leader in the House of Representatives. I am a representative from Bibb County, District 143, best county in Georgia. And I'm in I see, Mr. Chairman. But I'm an optometrist by trade. I used to be. Now I'm the leader, and so, yeah, I'm 27 years old. Look at me, I'm aging bad.
thank you, and we're delighted to have our staff with us. That they're the folks that really make this thing run and the glue that holds it all together for us. From our House Budget and Research Office, Tara Bookholt right here next to me, Morgan Hall and Amber Mack over there, and Justin Speck is here with House Media helping us to work all that out. Have I got everybody? Haley Glau, there. Haley in the Speaker's office. Haley, glad to have you with us too. I want to welcome everybody to our 3rd meeting of this House Study Committee on Certificate of Need Modernization. And again, thank our friends at Albany Tech for hosting our meeting here today. I'm Butch Parrish, and I want to thank Speaker Burns for allowing me to chair this committee and for appointing members who have clearly been chosen for their subject matter expertise, their legislative knowledge, their real-world experience, and overall depth and thoughtfulness. And I want to just take a couple of minutes and go over, make some remarks that I've made before, but I know that some of you that have been here, you've heard me say this before, and there's some new faces here too, but it's worth repeating, and I want to make sure everybody understands that. Some of what I say today will be a repeat that we had at our first and second meeting, but I want to tell you just a little bit about CON and what we're doing. Today, in response to House Resolution 603 that was passed last March, we began the third of our 4 planned meetings on Certificate of Need modernization. And some of you might ask, why modernization? But as many of you know, CON was first mandated by the feds in 1974 and shortly thereafter adopted by Georgia and all the other states. The feds repealed the mandate in 1986, and subsequently the 50 states have gone their separate ways in either repealing, amending, or continuing CON regulations. And of course, Georgia has since modified its regulations several times, but given the rapid evolution of healthcare in this country, I think it's very appropriate that we investigate the structure and the regime best able to provide 11 million Georgians with cutting-edge healthcare that's both accessible and affordable. As Speaker Burns has articulated on many occasions, moving healthcare forward in Georgia is one of his top priorities. And this study committee is intended to be a vehicle that will move us all in the same general direction, making improvements, clarifying ambiguities, and putting behind us as many roadblocks as we possibly can. And I want to be very clear that we do not come to these meetings with our minds made up about what the future of CON is. We'll rely on no preconceived notions. We do want to hear about the issues, the problems, and the concerns, but our focus needs to be on discovering the solution to these complaints. We want our eventual recommendations to be based on facts, evidence, and fairness. And I don't have to tell this room that healthcare is a complex subject. While we do want to study the issues and the opinions from every point of view, which is why we're holding meetings. We've met in Atlanta, Augusta, now in Albany, and then we'll go back to Atlanta to ensure that we get full consideration of various situational perspectives around the state. Our final meeting will be in Atlanta, October the 10th. And my expectation is that this committee will subsequently produce recommendations that can be drafted into legislative remedies that encourage providers to offer preeminent health care, whether it be routine, emergent, or traumatic, that is more affordable and increasingly accessible to all Georgians. Now, with having said that, let's move right into our agenda. We've got a full agenda today, and we want to give everybody an opportunity to present to us, but we also have a schedule that we want to adhere to. So we'll begin our meeting, and our first item on the agenda, Anna Adams from the Georgia Hospital Association.
Morning, Mr. Chairman. I'm going to try not to make this have feedback. It is kind of feedback a little bit, isn't it? Okay, we're good now. Good morning. I'm Anna Adams with the Georgia Hospital Association, and I want to start this morning by saying that I am here today to support streamlining and modernizing the Certificate of Need process. And I'm excited to share with you today some of our recommendations from our GHA work group. A couple of documents that you have today in your packet. First is our PowerPoint, which will be on the screen above. And then additionally, we have the Certificate of Need recommendations page, which is 11 pages long, and it goes through each of our recommendations in detail. We'll talk about some of those today, but I'll also reference back to this section because it's organized a little bit differently from our PowerPoint. So I want to start by reminding you all that GHA did host a number of meetings. We created the GHA Certificate of Need Work Group. It was comprised of 19 diverse members from our membership. We have more than 140 hospitals in the GHA membership, ranging from small rural all the way up to large urban. Our CON work group really reflected our membership as a whole. We had representatives from inpatient rehab facilities, psych facilities, system hospitals, standalone, rural, urban. We wanted to make sure that as we were thinking about certificate of need, we had the input from each of those different facilities and how they would be impacted. You may remember that at one of the previous meetings, we asked you all to think about healthcare from a holistic perspective, from a patient perspective, and not just how does CON impact access, but how do other changes, statutory, regulatory, have an impact on patient access as well. So this work group, as we had our meetings, really considered what are the impacts to physicians, what are the impacts to freestanding imaging facilities, what are the impacts to hospitals, but most importantly, what are the impacts to patients as we're talking about these changes. So on this first slide, you'll see a listing of each of our work group meetings. You'll see that we started in April, so this has been a really robust process. There are listed there beside each meeting date the topic of those meetings, and these were very robust meetings. We had in-depth discussion, we did a lot of data review with the committee members, and just because you don't see the title there of a particular CON topic doesn't mean it didn't come up for discussion. If you can think of it from a CON perspective, we talked about it, and we tried to find areas where there was agreement that some relaxation, modernization, and streamline would be very beneficial to patients, and I think that's what you'll see reflected in our recommendations. Last week, on September the 5th, we got unanimous consent from the GHA board to move forward with these GHA recommendations, and what we wound up with was 14 recommendations for changes to the Certificate of Need program. Some of these changes you'll see come with some sister component types of recommendations. So for example, if there is a recommendation for a change to CON, there may be other measures that need to be implemented in concert with that CON change in order for it to work effectively. So you'll see that throughout. This is GHA's new CON position, and I'll note that we have modified our CON position statement. Our previous statement cited, among other things, that GHA wanted to protect the current Certificate of Need process. It does not read that way any longer. It now says GHA supports a state health planning process that ensures access to all healthcare services for Georgians. Meaningful, targeted changes to the Certificate of Need process, combined with reforms to other components of the state's healthcare system, will help all patients have better access to comprehensive and affordable care options, while also protecting those essential but vulnerable services that are vital to the health of our communities. And I hope that through this statement, we've captured what the work group is trying to accomplish as well. So just a kind of brief overview, as the work group met, we considered what is CON, what is the purpose? And that seems like it's a very elementary question, but when you boil it down to that, you really kind of get back to the root of what are we trying to accomplish when it comes to providing healthcare services to patients in Georgia. And I think the main points and takeaways were that CON currently is a community-based health planning process. We want it to be very community-focused. The needs of your local community have to come first if you're a healthcare provider. Ensuring the appropriate allocation of healthcare resources. We want to make sure that the healthcare resources that are available within a community meet the needs of every single patient, and that doesn't just mean one type of service line. It means a collection of all the service lines to meet that patient's need. Requiring providers to demonstrate a need within their community. Again, it's that community tie. How do we make sure that we're thinking about that local impact for these policies that we're proposing? And then finally, allowing the state to preserve and ensure access to safe and affordable health care for all Georgians. We recognize that sometimes at the community level you can get a little bit myopic, and so we do depend on the state to think about the needs of all of Georgia's residents. Georgia's current stated purpose for the Certificate of Need program, this is not GHA's policy, this comes from the official code of Georgia, this is statutory language. The policy of the state and the purposes of this chapter are to ensure access to quality care services and to ensure that healthcare services and facilities are developed in an orderly and economical manner and are made available to all citizens. I won't read all of this to you, but I think again it captures the goal of what we were trying to accomplish. And then final bit of background. How does CON currently protect and ensure access to care? We're ensuring access to comprehensive services. We're ensuring we have a proper resource allocation. We're ensuring we're promoting charity care, encouraging public input, and facilitating planning and policy, and then finally, quality control. So that gets us to our GHA recommendations. And I'll start by saying, again, many of these recommendations are complementary of each other and work in concert, so we have organized them throughout with multiple recommendations on a slide so that you can see how they work together. But all of these recommendations provide greater access to care by streamlining and modernizing the current process. As policymakers, again, can continue to study the Certificate of Need program, we recommend any modifications be considered in the context of the state's entire healthcare system. And so that may be at the local level, at the state level, providers who are local only, providers who are statewide, physicians, hospitals, you name it, we've tried to cover it. So our first set of recommendations is directly related to the regulatory process. Recommendation, this first bullet, if you look in your corresponding packet, the GHA, it's recommendation number 2, which is to update the state health plan at least once every 5 years. The state health plan is where the need methodologies for each of these service lines live. Many of the state health plans are more than 20 years old, and the CON work group feels that that's not a reflection of the current state of our health system. Many of those recommendations are very outdated, need to be updated, and we think that this will have an impact, significant impact on physicians, surgery centers, hospitals, communities, and patients in general. When those need methodologies are updated at least every 5 years, we're ensuring that we're current on how we're asking hospitals and other providers to justify their certificate of need request. The second part of that is to address concerns about the ability to obtain a CON for ASCs and other services. When we talk about need methodology, we've heard from many proponents to getting rid of CON that they don't even bother to apply, that they're concerned that they wouldn't get a CON even if they were to go through that process. We feel that updating the need methodology with proper input from each of these providers through the regulatory process would really alleviate a lot of those concerns, because you are modernizing what you're asking these providers to prove. The second bullet here, also number 2 in your packet, is limiting opposition to in-state entities whose service area substantially overlaps. This is an important one. In-state entities right now can oppose other entities' certificates of need. However, there was a recent case where an out-of-state entity opposed a certificate of need in Georgia. The department used its regulatory authority to disallow out-of-state entities from opposing certificates of need. We are proposing that you make that a statutory fix so that no out-of-state entity can oppose an in-state CON. The second part of that, service area substantially overlaps. We've had a lot of discussion over the years about opposition and how long that opposition process takes, how many people are deterred by opposition. So this is going to significantly limit the number of parties who have standing to oppose. The term here, substantially overlaps, we've defined in our recommendations as 10% of your new patient revenue within a single zip code for the proposed location of the new service that you want to oppose. That's very complicated. So if I want to oppose someone's certificate of need, then I have to prove that 10% of my new patients would come from a single service area in their service area. We have had a lot of back and forth about what that means. What does a service area look like? It's going to vary by provider, but it does put the burden of proof on the opposer to show that they have the standing to do that. We think this is going to also significantly limit the number of opposition cases that the department has to handle each year. So this, I think, is a really big step that would be helpful for physicians, surgery centers, hospitals, anybody who typically has to apply for a CON now, because it does more clearly define who has standing to oppose. The third bullet on this page, eliminate the certificate of need appeal panel. We've had a lot of discussion over the years and frustration about the current certificate of need appeal panel and their ability to manage the caseload that's coming through the department. It's a very small panel. Sometimes that can take a really long time to work its way through the process. So we are proposing eliminating the Certificate of Need appeal panel and instead moving those appeals when they are necessary to the Office of State Administrative Hearings. They are currently very well versed in dealing with appeals. They are a well-oiled machine over there, and we think that moving this process over also frees up the department to be able to handle things like updating the state health plan every 5 years. And then finally, for the regulatory process, limiting the commissioner's review to 30 days. So not only have we eliminated here the number of parties who can oppose, but we have condensed the process for opposition and made it much shorter. Moving on to the next slide, thresholds. GHA is recommending the elimination of capital expenditure thresholds. These are for all provider types. So if you have to get a CON currently for a construction-only capital expenditure, that threshold is right at $11 million right now. We're going to propose eliminating that altogether. So if you want to do a construction-only project, a capital expenditure, you would no longer have to get a certificate of need for that. You would simply go through the department's process for determining that you don't need a CON. It's called a letter of determination, but basically just proving we don't need a CON for this project. Again, that's going to free up the department for a lot of different other projects, but also take some of the things off of their plate. The second point here, eliminating the equipment expenditure threshold. Same thing as the previous recommendation. This would impact physicians, hospitals, and imaging centers that were grandfathered prior to the 2008 changes. That last part is kind of a caveat. When we made a change to the Certificate of Need law in 2008, we treated existing freestanding imaging centers differently than we did post-2008. So this just evens the playing field between those existing and new freestanding imaging centers. Perinatal services is an area where we've had a lot of discussion with the Certificate of Need work group. I know you all, as a General Assembly, have spent a lot of time over the last several years focusing on maternal mortality and how do we make changes to impact especially rural areas for these pregnant women and postpartum women. So GHA is recommending for this to increase, first and foremost, access to pre- and postnatal care in Georgia's maternity care deserts. That is not specifically about Certificate of Need, but this is one of those recommendations that I discussed previously that comes with kind of a package deal. There are certain things that have to go along in concert with this recommendation in order for it to work and for us to see real changes. The first being increased financial support for obstetricians, certified nurse midwives, and family medicine practitioners. We want to find a way to incentivize these providers in healthcare deserts, specifically maternal care deserts, and in rural areas, and some of that is going to come down to funding. The second point in increasing access to pre- and postnatal care is expansion of access to telehealth services. Last year, you all, as a General Assembly, passed a pilot program to allow for telehealth services for prenatal care for women, and we would propose potentially expanding that or exploring additional options for telehealth services. The third bullet here is optimizing scope of practice regulations to maximize access to safe and affordable care. Scope of practice in particular for pre- and postnatal care is something that we really want to try to focus on to make sure that we can get providers into those areas where no providers exist, and that may warrant having a conversation about scope of practice in those areas. We would rather have a provider than no provider. And then finally, tort reform measures that can ensure providers feel safe to practice in varied settings. This is incredibly important, especially for OBGYNs. It is a dangerous business caring for women who are pregnant and delivering babies, and having the ability to recruit those providers down to rural areas in particular depends upon whether or not they feel safe to practice. In addition to that, being able to afford medical malpractice insurance is a really important piece of this tort reform package. And so we would argue that having that in place would help move Georgia forward in the maternal care space. If all of these things are implemented in concert with that, GHA is proposing exempting basic obstetric services for hospitals, and revising the licensure standards to ensure quality and volume standards. So this means that hospitals who want to offer basic OB services, deliver babies, and have a nursery would be exempt from certificate of need. Instead, we are proposing adding additional requirements in the licensure standards to ensure that quality metrics are in play and that certain volume standards are met so that you do have that safety. There we go. The next slide touches on exemptions, new exemptions to certificate of need. The first is that GHA is proposing expanding current exemptions to allow a closed facility or service line to reopen within 24 months. The current statute says if you close a facility or service line, you have 12 months to reopen it under the existing certificate of need. We are proposing doubling that to 24 months, so long as that closure was not the result of some kind of negativity on your license or some kind of problem with how you've been operating. The second point here, new exemption to allow health systems to transfer existing beds or services from one hospital or campus to another existing hospital with the same service within the same system and within a 10-mile radius. This seems complicated, but to make it a little bit clearer, this would mean if you have two hospitals within the same system, one hospital is frequently on diversion, the other hospital has empty beds, it would allow them the ability to transfer those beds, as long as they're the same service line, to that facility that needs those extra beds. Third point here, expanding current exemption to allow existing hospitals to increase bed capacity by the greater of 10 beds or 20% every 3 years if the hospital has maintained at least a 60% occupancy rate for the previous 12 months. This provision exists in the statute now, although the threshold is much higher. So this makes it easier to add beds to existing facilities moving forward. The current threshold is at 75%. We're proposing lowering that to 60%. The current calculation for that is also at 2 years. We're proposing every 3 years, again, to alleviate some of the burden on the department. Fourth point here, expand current exemption to allow healthcare facilities in urban counties to relocate within 5 miles of the existing facility. Currently in rural counties, you can relocate a facility anywhere within the county border. This is moving the current law for urban counties from 3 miles to 5 miles to give them a little bit of a broader range. The next set of recommendations is maybe the one that took up the lion's share of our conversation with our GHA CON work group, and it's related to psychiatric and substance abuse services. And I'll start by saying if CON changes and these other recommendations are going to be considered in the form of legislation this next session, GHA would recommend that these psychiatric and substance abuse services be considered separately because they are so complicated. So psychiatric services are currently regulated by both the Department of Community Health and the Department of Behavioral Health and Developmental Disabilities, and so there are 2 separate lines of recommendations here. The first, expand access to crisis services to stabilize the behavioral health safety net. Department of Community Health provisions, equitable access to services in Medicaid fee-for-service and managed care programs. Enhancing Medicaid payments to fully cover the cost of care, and creating a new Medicaid-directed payment program for private psychiatric hospitals. These are 3 separate recommendations that all fall under the purview of the Department of Community Health. Under the purview of the Department of Behavioral Health, creating sufficient safety net capacity of crisis services to serve the needs of all publicly insured and uninsured behavioral health patients. I'll add here that crisis beds right now that are operated by the state are already exempt from certificate of need. Second point, enhance payments for state contracted inpatient psychiatric beds to fully cover the cost of care, so matches the Department of Community Health's responsibility in that previous bullet. And then finally, establish a direct funding mechanism to reimburse hospitals for the cost of boarding behavioral health patients in the emergency department and transporting patients to emergency receiving facilities. Currently, when a behavioral health patient is in a hospital emergency department, even if that hospital does not offer behavioral health services, they are not being reimbursed for that care. There is also a requirement that for patients who are being held under a 1013, there be a 1-to-1 staffing ratio. So as we think about workforce problems within hospitals, having that 1-to-1 staffing ratio really pulls those very much needed nurses off of your emergency department floor and dedicates them to one patient, which further limits the amount of patients you'll be able to take into your ER and backs EMS up. It's a snowball effect. Once the behavioral health safety net is stabilized, GHA recommends creating a new exemption for inpatient psychiatric and substance abuse beds. With those expanded beds becoming a part of the DBHDD inventory to treat behavioral health patients in crisis, uninsured. So that would simply mean that if you have a new bed added under the CON exemption, that bed would be a contracted bed with the state for those uninsured patients. And then our final recommendation is related to the statutory organization. This seems like a really short slide, but basically this means a rewrite of Title 31, Chapter 6. And the issue with the current Certificate of Need statute is that it has been rewritten so many times over the years that it is difficult to understand and it's difficult to follow. And so even going through the statute for the GHA CON work group, we had to reference back and forth several times to see it's required here, but here it says it's exempt. And so we do feel that there are probably a lot of individuals, providers, facilities out there that would like to apply for a CON or have considered applying for a CON, but are so overwhelmed by the statute and are unable to follow the logic of the statute. So the proposal here is that we completely rewrite the statute so that it makes sense, it's streamlined, it's organized, and it's easy to follow. And those are GHA's recommendations, and I'm happy to answer any questions.
Thanks for your presentation. Do we have some questions from the members of the committee? Dr. Newton?
Well, I appreciate that GHA's work on this. They certainly have spent a lot of time and come up with some things. One of my questions kind of regards the new expanded areas that you mentioned. I think on several issues, the capital requirements, the community-based planning. It seems like once, even though you're shortening the commissioner's time and you're eliminating the appeals panel and moving it to a different administrative role, it seems like at least what I would call the horror stories of CON are the ones that go on for 2, 3, and 5 years. And one of the struggles I have, if y'all dealt with this on, if once there's anything about CON, if it's not exempted and there's no legal opposition, then the courts don't get involved. Once the courts get involved, it's out of all of our hands. It's out of the legislative branch's hands. It's just, and you're talking, we've heard tens and hundreds of thousands, maybe millions of dollars in legal fees, significant multi-year delays. Have you addressed anywhere in here, because if you keep the appeal panel, if you keep something subject to CON and you say, well, this 10% service area overlap, for example, that just sounds ripe for disagreement. And disagreement means somebody's not going to like what the decision or the appeal committee that's now in DOAS or wherever, then they're going to take it to court. And once you take it to court, we have just no offense to the legal system, but my goodness, the time and the delays and the expenses have to be something that every entity that's thinking of investing in healthcare to meet some needs they think they see. Is there a way to more broadly just go on and exempt some things from it so that, or is that just too uncomfortable? Like I said, that 10% overlap of service area just sounds like the number that if you oppose it, And one number you do says 8% overlap and one says 12, so you go with your 12 number and you file a opposition and you lose 2 times administratively. There's nothing in here to stop them from going to court, right? And saying, which is now minimum, I think, 2 years.
You're correct. There is nothing to stop it from going to court. We do want to preserve each party's right to appeal. We do feel, though, that the Certificate of Need Appeal panel right now, the members that serve on that are attorneys, whereas at the Office of State Administrative Hearings, they are judges. They have staff. They understand how the judicial process works. And so it's a little bit of a different playing field. We have exempted several things in our recommendations, and so we feel like that's going to minimize the number of cases that would find themselves in this position in general. However, if you have additional recommendations, we're always happy to consider those. We had so much discussion about the process of applying and appealing and who can oppose, et cetera. And this is where we found that most of our members felt comfortable living with it while also giving some things up. We felt like this was kind of the middle ground.
The regulation's 35 miles, is that correct? Or is that who's eligible? That, at least that seems, as long as it's defined as the crow flies or whatever, that seems more concrete than 10% of our expected new patients may come from this other area. That was the one that kind of struck me as ripe for new litigation, but I'd be glad to talk more. Thank you.
Thank you.
Thank you for your presentation. I have some questions around the perinatal services and the fact that we will exempt basic OB services from a CON. Now, as an obstetrician gynecologist who trained at Grady, I don't think there are any basic OB services, because the delivery turns into a complication. Most of the time is unanticipated. So I would need some clarification on what you all are defining as basic OB services, because one of the opportunities, unless I'm misunderstanding, is that you must be able to manage the patient to the fullest extent. And generally, in an obstetrical situation, it comes down to usually a hypertensive crisis, right, that occurs unexpectedly, or a postpartum hemorrhage. And so, and all of those pregnancy deliveries typically will start out, quote unquote, basic. Unanticipated, there's going to be a challenge. So can you get some clarification on what you all mean by that?
Yes, so basic obstetric services would cover the scenarios that you've cited. In addition to that, it would cover cesarean sections when necessitated. It would not be a high-risk labor and delivery unit. So for example, if you had a patient who was pregnant with multiples, that wouldn't be basic. However, most hospitals who are doing labor and delivery have to meet this basic standard anyway. So it's not anything below what the current standard is if you're a labor and delivery facility.
So you still have to have the full capacity to
Yes.
take care of any type of emergent situation
Yes, ma'am.
that occurs in an uncomplicated pregnancy,
Yes,
an
ma'am.
anticipated uncomplicated pregnancy. Thank you.
Anybody? Chairman Cooper, you have
Okay.
a question?
To follow up with Dr. Rice, I think one of the problems we have, when we had the mortality review study group looking at it, one of the problems that we have are with the smaller hospitals. About 85% of our hospitals have now been trained on the bundling process, which is not a bundle of anything, but it's a intense training of nurses, specific people in each of the hospitals and team that are trained on what to do with hemorrhage. When they went out to the smaller hospitals that deliver 1 or 2 or 10 babies in a year, they are not staffed to designate specific people to learn the bundling process to be prepared in emergency. They just told our people as they went out to try to teach them that they couldn't participate. And it is a problem with the smaller hospitals in being prepared for what Dr. Rice is talking about, those emergencies, and especially as we see more what used to be, well, it wouldn't have been, I guess they would just been gone untermed, but with obesity and hypertension and diabetes that we are seeing across our state, there really aren't really many older women to say that they can handle basic. OB is really stretching it nowadays because the percentage of what would be maybe not diagnosed as high term, but I mean high risk, are really high risk. So I have real problems with that too, Dr. Rice.
I appreciate this statement because one of the things that we did discuss and that comes up often is that certificate of need is one piece of this puzzle, but then there's also licensure and accreditation. And so one of our recommendations here for the basic obstetric services is to include many of these quality standards in the licensure requirements. So while they are exempt from certificate of need, the state has the authority over how we are licensing them and what we are requiring of them to keep up with that licensure. And so that's one of the things that I think is worth additional conversation afterward as we're talking about revising that licensure standard, is how do we make sure that when they're licensed, they are safe and they are meeting that standard.
Well, and just so people will know in this room, we have a new nurse midwifery school in Milledgeville at the college there. They are taking, and have looked at the last classes, they are taking nurses, experienced nurses from the rural area to go through the midwifery program so that we could have a hub and spoke type of system where we have highly trained nurse midwives out in the rural areas but they work with a hub, larger hospital to deliver the babies. And they're doing a great job at that new midwifery school in Milledgeville. It's one of our state schools, and they're doing a great job, especially of recruiting experienced nurses from rural areas that will go home to where they live to be nurse midwives and to help us with that system. So that's doing.
So one of the things I want to make sure we have some clarity on this. For the licensure and accreditation, the ongoing training is already a part of that, right? The ongoing training and ability to demonstrate that you can manage the postpartum hemorrhage, et cetera. That is already a part of that.
It is.
And we are not doing that well in the state.
I think for the facilities that are offering labor and delivery services, they of course will be checked on that when their licenses are checked. Joint Commission checks on that as well.
Right.
GHA actually has in the past had a grant where we have gone out to educate hospitals on those bundles with hemorrhage carts, things like that, how to use them. One of the things that I think has made this really challenging, again, is the workforce shortage. And when you have as many travel nurses as you have, and they're going from facility to facility and coming from one state to another, those standards don't always match state to state. And so hospitals work really hard to make sure that when they get those nurses in from other states, that they understand what is expected of them, what those requirements are. But you're correct that it is already in the licensure standard, but that doesn't mean we can't beef it up.
So one of the things that you all would be proposing, if we exempt from CON, that we put in additional quality and safety measures that would become a part of the licensure and accreditation process.
Yes, ma'am.
And do you all have an evidence-based approach or data that we would want to add to ensure that we can have something that we can monitor that's going to be different than what we already do?
So GHA we work closely with the American Hospital Association, so we have contacts at each of the other state hospital associations, and as a part of this CON work group, we reached out to the other states and have said, you know, what do you exempt? What does it look like when you exempt it? And one of the things for this in particular that many of the states have pointed to is the need for beefing up that licensure standard. Florida in particular was one of the ones that we talked to about the perinatal services piece, and so they did this through their practice. And so we have things to point to that have worked in other states, things that they have done specifically, but we also rely on external groups, you know, March of Dimes, things like that, for the types of safety requirements that they would like to see in those facilities.
So when Florida
helping
did
mothers, helping
this,
babies.
excuse me, so when Florida did this, when they implemented those new requirements, did they see an improvement in outcomes?
It's been too soon.
Oh, okay.
They did that in 2019, and then COVID has happened, so we've got some time to get some data.
Newton has a question.
How does CON protect and ensure access to care? And some, maybe you may not be able to answer it now. It's talking about access to comprehensive services, even if they aren't profitable. And I was kind of curious, is there a list somewhere that GHA could give us of which things that a hospital does? And I work in a hospital that, well, actually, frankly, it's full service, but it also spent $20 million expanding the ER, which many people list as a money-losing thing. Then they put billboards up touting their lower wait times so that we'd have more ER business. And then a few years later, they added and made it a level 3 and a 2, and now level 2 trauma center, which normally is listed in the things that you lose money on. And this is a for-profit owned hospital. I'm assuming they're doing it. They've added GME, which is often said as one of the costs of that's not profitable. So I'm puzzled. Is there a list of service lines, or is it more the typical patient has better insurance in a particular area? I mean, I know ORs are usually listed and imaging maybe, but is there a list somewhere that we could get of what are the community service ones? Blood bank, for example. I don't know how it reimburses, but who determines what's the cherry picking that somebody might want to come into a community and hurt the local health system by cherry picking off the few profitable things there are? Is there a way to get a list of what's considered profitable? I know,
Yes.
For example, OB is mostly Medicaid in Georgia, or 60-70%. That may not be a profitable service. I'm not sure.
For some it is, and for some it's not. OB depends on the area. ED is typically not a profitable service, but what you'll see is hospitals are invested in their community. And so even if they're doing that at a loss, it's the right thing to do. And they use the profitability that they have from services like surgeries and imaging to supplant the revenue.
So
from
those are the two on the list that are profitable.
Generally speaking, yes. Some hospitals may have some services, again, depending on their payer mix, that are above that break-even line. But for many, emergency services, inpatient services, we don't typically go above the break-even. Yeah, and so we have to find a way to supplant that revenue. But I do have a list.
Okay, thank you.
Sort of following up on that profitability angle there, in a couple of places, particularly psychiatric substance abuse services, there's a couple of references to fully cover the cost of care or things like that. Have you all come up with a number that it would cost to do that?
Total budget number
Yeah.
for the state, we can get that for you. That is gonna, again, depend on the number of patients we're insuring. Right now, the fee-for-service is not included, so that's something that we would also have to get additional revenue for in the
Right.
budget, but we can get you a number.
I think that'd be helpful because, a lot of this is good and we want to look closely at it, but part of it is going to depend on the cost of getting it done as well. So we want to keep that in mind as we continue. Chairman Cooper, you had a question?
Yeah, I forgot what it was. It was a follow-up on the OB. It's fine.
Leader Beverly has a question.
Thank you, Mr. Chairman. I want to draw your attention to recommendation 9 and 10. And I have a question around diversion. Because right now you have people are checking into emergency rooms and they're in these overflow hallways. And it is a problem. I mean, you're violating HIPAA, OSHA, I mean, you name it. I mean, you have folk who are lined up in hallways all over the state of Georgia, and this diversion not quite working. And when I look at 9 and 10, it says the diversion can happen in spaces where there are existing hospitals, right? So if you have this overflow, you have a problem, you got to divert, where do they go if you don't have a facility? And so my question to you specifically is, what do we do with these patients who are in these hallways? Is there an opportunity to create a system through CON that we can offload some of those folk into a new facility that may not be existing currently? Because it's a real problem right now, and it hasn't been addressed, I think, in this recommendation process, and it's causing some real problems for folk around the state.
It is a challenge, certainly. And again, this gets back to workforce. Hospitals are having difficulty discharging inpatients, which means that you can't move emergency patients into inpatient beds, which means you can't bring EMS traffic into the ED. We're seeing this all across the state. It's not specific to urban areas. We're also seeing it in rural. Many of our hospitals, especially regionally, have close contacts with other facilities, and when they get to that point of crisis, and they need to go on diversion or they're already over capacity, they have transfer agreements with other facilities. We're running into challenges right now with having enough EMS to do that non-emergency transport between the facilities themselves. And so that is an area where outside of CON, we could really use some assistance from the General Assembly in getting some additional funding for non-emergency medical transport and some support there to move patients out of the inpatient setting to post-acute setting. And I think you're going to hear later from the Nursing Home Association, and they can talk as well about their workforce challenges. But having beds shut down in nursing homes, post-acute care, even at the inpatient setting, means that you can't manage that same capacity, and we can't do that patient throughput in a way that's efficient.
First one is, I was a little bit surprised that, and maybe I'm just missing it, that there was no recommendations that the Georgia Hospital Association put around guidelines for notice of closure to hospitals and the timing that one would have to provide the community for when a hospital is going to close, and a program or process in place for the transition of those clients. It would seem that what we all just experienced with the Wellstar closure in the Atlanta region and the number of hospitals that were impacted by that, we would have had some discussion about that and how maybe we use CON to support and put some regulations around that. So that's the first, and then I have a second comment.
We did have that discussion as a part of the work group. You may be aware that right now the Department of Community Health has a proposed rule out related to notice of closure. GHA did comment on that notice. There were some questions that we had about the closure of a specific service line if it was unexpected, for example, due to workforce or due to some kind of facility emergency. But then there was also a lot of discussion surrounding how much of a notice is too much of a notice so that it expedites the closure itself. For example, if the notice requirement was a year, suddenly your vendors are pulling out, your workforce is looking for other jobs, and so while you thought it was going to be a year, you've now lost your workforce to the point that you're forced to close much sooner. And so while we do agree that notice is important, we want to make sure we're doing it in a way that's thoughtful so that the community can maintain that service line for as long as possible, and that we're exploring options to find a way, again, to supplant some of that revenue so they don't have to make that choice to close. So because of that rule being out there right now, we're kind of waiting to see what happens next with the department, and I expect to see that maybe on one of their agendas soon. But I'm sure that's not the end of that discussion.
Yeah, I would hope that you all will take a position that is strongly viewed from the lens of the patient and the community that's going to be impacted.
Yes, ma'am.
And while I agree that vendors and others are part of the community, I'm talking about the individual patients who lose access to care.
Yes, ma'am.
And then my second question is around your general statement that you all made. You said major modifications to the CON program should become effective only after other changes to stabilize the state's healthcare safety net are in place. Can you give us some examples of what you all mean by stabilizing the state healthcare safety net so that we understand what you all's perspective is about before you would recommend any of these other changes?
Yes, so throughout, as we have these recommendations, you can see in some of them perinatal services was one, psychiatric was another, where we talk about stabilizing the state's access to psychiatric services. In the psych one in particular, we talk a lot about funding and access to coverage for those patients. Stabilizing that behavioral health safety net is very important to ensuring that even if we change CON, it would be effective. So without those two working together, we don't think either one would independently be helpful. So that's what we mean when we talk about stabilizing.
And I'm sure you all have data that could be supported about how those stabilization efforts would be beneficial.
Yes, in particular, again, for the behavioral health piece, we have lots of anecdotal stories of patients in hospital emergency departments for 30 plus days because they're uninsured and we can't get them into a state bed. And so the cost of that, what that means when you're treating them in an emergency department setting versus the appropriate care setting, which is a crisis bed, is astronomical. And so we want to make sure that we're putting those resources in the right spot so that it is in the best interest of the patient.
Yeah, sure.
Thank you for the thoughtful recommendations. With these recommendations, was there an opportunity to review the anticipated impact, for example, other states that eliminated the capital threshold and impact on access and cost? So really taking to review the impact of the recommendations made.
We have looked at other states and what they do from a certificate of need standpoint when it comes to things like those expenditure thresholds. However, because each state also has different licensure standards, it's really hard to compare. It's not apples to apples. And so we can look at what's happened in other states, but you also have to take that in context with what the state is doing from an oversight perspective. So it's kind of hard to answer that question.
That's fair.
Any other questions or comments from the committee members? Sharon Cooper.
Okay, back to the obstetrical part. At the end of that group of suggestions is the one about tort reform. And, you know, you had said that we shouldn't, you know, do anything about the ones earlier unless they all occurred. And I'd like to know what magical wand you have from GMA about helping us pass tort reform that would help in that area.
This is a big deal to our membership, and it's a big deal to providers. We want to make sure that providers feel safe to practice in Georgia. And what we're hearing from our providers that are hospital-based and even those within the community is it has gotten so expensive to even afford medical malpractice insurance that they're afraid to practice, that even in some cases are practicing defensive medicine because they are afraid of these runaway jury verdicts and just the amount of really bad press that goes along with those lawsuits being filed. And so we are willing and ready to step in and be as helpful as we can on tort reform. Some of the things in particular that would be helpful from a hospital perspective are trial bifurcation and addressing phantom damages. We have in the past had conversations about those. There have been bills introduced, but we really feel like now is the time to do something about this because it seems it's only getting worse.
Heartily on that, the need for it. It's just that, and so what basically though you said was we shouldn't do the other things unless we can get tort reform.
I think tort reform is especially important when we're talking about the perinatal services piece.
Any other comments or questions from the committee? And thank you for the presentation. I want to thank you and your organization for trying to help us get to where we wanted to be, which is don't just come and bring us the problems, but offer some solutions. And while we've got a lot of things to consider here, some are much easier to consider than others. So we'll be looking at those as we go through. Thank you very much.
Thank you for the opportunity.
Next on our agenda, Monty Veazey and Chris Dorman, Georgia Alliance of Community Hospitals.
Thank you, Mr. Chairman and members of the committee. I'm Monty Veazey, President and CEO of the Georgia Alliance of Community Hospitals, representing over 100 not-for-profit hospitals, from the smallest rural critical access hospital to the large multi-campus systems. I first want to talk about some data we shared earlier. The Georgia Alliance of Community Hospitals back in April engaged Dr. William B. Cleverly of Cleverly and Associates out of Ohio State University, a nationally recognized firm specializing in hospital financing, to study the effects of CON. Dr. Cleverly presented some of this material and you should have copies in your notebooks. Dr. Cleverly compared Georgia, Arizona, Colorado, Texas, all non-CON states, to address the effects of CON on price, cost, and profits, and it found that Georgia patients pay significantly less for inpatient care, routine room rates, emergency department visits, and Georgia hospitals had lower markups, lower net revenue per patient, and lower operating margins than in any non-CON states. CON has added a downward pressure on hospital charges, according to Dr. Clever. As we listened to testimony throughout the summer from other speakers, no one's ever mentioned an important factor and that affecting hospital finance, and that is Medicaid expansion, which Dr. Cleverly touched on. Comparing Georgia to other states with CON and without CON, and considering Medicaid expansion, Dr. Cleverly found that Medicaid expansion is associated with lower hospital charges, high operating margins, and an important measure of financial health care. Finally, I want to address the issue of CON preventing huge numbers of new facilities across Georgia. Today, the Department of Community Health grants more than 90% of requests under CON law for providers to open up new facilities or add equipment. At the same time, it has safeguarded hospitals from threat of new providers that may come in. I'd like to introduce Chris Dorman, President and Chief Executive Officer at Southwell in Tifton. Chris has served as TIF Regional President and CEO since 2017. Under his leadership, TIF Regional has thrived and expanded to meet the needs of patients in the service area. Chris will discuss the financial issues with keeping a hospital open and how Certificate of Need protects hospitals, especially in rural ones like TIF Regional. With that, I'd like to introduce Chris Dorman.
Thank you, Monty. Good morning. Again, I'm Chris Dorman. I serve as the President and CEO of Southwell, a not-for-profit health system serving 12 counties in south central Georgia, which includes Tifton Regional Medical Center in Tifton, Southwell Medical in Adel, and several clinics, physician practices, and other healthcare facilities across our service area. We offer community access to more than 170 physicians with expertise in over 30 specialties and have 2,700 talented staff members. We provide around $77 million in charitable and indigent care and have an $899 million impact on the local economy. Our primary service areas include Tift County, Turner County, and Cook County, while our secondary service areas include Atkinson, Ben Hill, Berrien, Brooks, Coffee, Colquitt, Crisp, Irwin, Lowndes, Wilcox, and Worth counties. Our primary service area is rural and diverse, with roughly 32.5% African American, 7.5% Hispanic or Latino, 1% Asian or Pacific Islands origin. In the three-county area, we have slightly fewer than 66,000 residents, and our median income is $41,511 per year. I'm going to talk to you this morning about the fundamental financial challenges of running a rural hospital, and much of this will apply to all hospitals at varying levels. First, I want to define two terms that are very important in a discussion of hospital finance. First, I want to define payer mix, which is simply the percentages of our patients whose bills are paid by, first, Medicare, which pays about 87 cents on the dollar of the actual cost of providing treatment, and second is Medicaid, which also pays roughly 87 cents on the dollar. Third is what I call self-pay, which means individuals who have neither health insurance nor Medicare and Medicaid. For this, we recover roughly 5 cents on the dollar from these patients. And then fourth is commercially insured patients. The relative proportion of a hospital's patients who are paid for by those four sources is what we call our payer mix. Here's a simplified model payer mix in which we've made each payer represent an equal amount to make that math simpler. Let's say that our hospital bills 4 patients $100 each and needs the full $400 to keep its doors open. In this simplified example, the systematic underpayment by government payers and uninsured patients comes to more than half of the total needed for the hospital to cover its expenses. In some cases, there are other sources of hospital income. For example, several smaller counties supplement their local hospital's income with annual appropriations or a dedicated source of income. But that, in a nutshell, is the fundamental problem of keeping a hospital doors open. In 2018, the Alliance surveyed our members and asked about their payer mix. Here's what we found as an average. Medicare was 39.6%, Medicaid 25.1%, commercial 25.2%, and uninsured 10%. So it's not quite as bleak a scenario as the simplified version, but I hope you all have a better understanding for this challenge. So we lose money on nearly 75% of our patients and have to make up the difference with roughly 1/4 of patients who are commercially insured. That's the only way we can keep our doors open, and dealing with insurance companies gets more and more difficult each year as they seek to reduce their bills and maximize profit. You know, as a young aspiring physician, everybody always wanted to be featured in some magazine or journal, published in something, and you know, I was really happy to be published in Modern Healthcare magazine in December of 2022. Our hospital was actually featured in Modern Healthcare magazine with 14 other hospitals across the country. We were ranked 3rd in the nation for charity care, the most charity care as a percent of services that we provide. Most alarmingly, of the 15 hospitals reported, I was joined by 3 other Georgia hospitals. 4 of the 15 across the country were Georgia hospitals, our charity care. So that brings us to the second word I want to define, which is profits. You'll hear a hospital executive or lobbyist use the word profits, and you may say, aren't you supposed to be a nonprofit hospital? Why do you talk so much about profits? In today's economic environment, even the idea of a profit is a luxury, with many rural hospitals reporting negative operating margins. We're now in our 3rd year of a negative operating margin. But to clarify the term profit, we simply use the accounting term that means the difference between revenues and expenses, like any other institution, but we don't have shareholders to whom our profits go. As not-for-profit hospitals, all our profits are required to be reinvested in our communities. Those profits are what we pay for the educational programs, free screenings, prenatal community programs, and all the other things we do to help citizens in our service area be healthier and happier. Every 3 years, our hospitals are required to perform a community health needs assessment, and we use ours to help prioritize our healthcare outreach in our communities. Among our patients, we've identified transportation to doctor's appointments or the hospital as the top need. To address that, we have many programs to provide better access, just a few of which are: in 2019, we purchased a mobile clinic to help better reach medically underserved areas. Outpatient case management coordinators, free transportation service to and from appointments for indigent patients, but we're also limited by the options available in our areas. We've increased our telehealth offerings to help reach more patients remotely. We host free clinics for flu vaccinations for underserved and high-risk neighborhoods. We've provided in-school clinics to help reach students and teachers where they are, keeping our children learning and their teachers teaching. All those programs aim to improve patient health by giving them resources to improve their health and avoid sickness, but they cost money to continue. And the funding for these and many, many other programs come from the profits we can produce. In some cases, payer mix can vary dramatically within a region. A 2010 study of obstetrics by the Medical College of Georgia found the following for OB patients in the metro Atlanta area. Gwinnett County, 50% Medicaid, 20% non-citizen, 30% commercial. North Metro Atlanta, 10% Medicaid, 1% non-citizen, and 90% commercial insurance. As you can see, the difference between the payer mix of Gwinnett County versus North Metro Atlanta overall illustrates why the financial situation at Gwinnett Medical Center deteriorated to the point it needed to be acquired by a larger, more financially stable healthcare system. The situation in rural Georgia is much more dire. Clay County Medical Center is not a hospital, but for the people of Clay County, it's the only physician in town. And Dr. Karen Kinzel works emergency department shifts in an Alabama hospital to be able to keep her clinic open. It's not financially stable without her personal contributions. So that's the fundamental financial challenge in running a hospital today, finding a way to cover the shortfall caused by a payer mix that typically includes more than 50% of patients being covered by government programs that pay less than the cost of treatment, and a substantial percentage of uninsured patients. That's the revenue side. On the expense side, we try to contain our costs as much as possible, but federal laws require us to treat any patient who presents with an emergency condition or an active labor. Federal regulations also specify a number of specialist physicians who must be available 24/7 in our emergency departments. Electronic medical records, which are also required by federal law, are enormously costly. If you recall the issue surrounding the $105 million cost to implement the Epic record system at Augusta University Health System, my cost was $54.2. Additionally, during the pandemic, Georgia hospitals reported having to pay as much as 3 times the normal rate for a nurse to bring in traveling nurses to meet the demands of patients, and the nursing workforce shortage crisis. Georgia still faces a chronic shortage of healthcare workers, especially nurses, but including almost every job in the hospital. I have 327 openings. Back to the revenue side, there are 3 main mechanisms state and local governments can deploy to affect our hospital payer mix. First is Medicaid expansion, which we understand to be off the table currently. Second is direct government payment outside of the fee-for-service model, like Irwin County's support of their local hospital through direct payments from the county. Those decisions are made by individual communities. Typically, though, the Georgia Heart Rural Tax Credit Program would fall under this category and has been a resounding success for many hospitals. And third is the Certificate of Need, which, along with ensuring patient safety and mandating specific levels of charity care, also helps prevent the erosion of the commercially insured base of existing hospitals. To illustrate how CON protects hospitals, consider this hypothetical scenario. A for-profit medical group decides to open an orthopedic ambulatory surgery center across the street from Coffee Regional, where they're going to perform hip replacements, knee replacements, and other orthopedic procedures. In reality, they're only going to be interested in working with commercially insured patients, which are notably in short supply in our community. I'd also note that the orthopedic procedures were among the most profitable in most hospitals. While this seems like a hypothetical scenario, this was my community 7 years ago. If we lost 10% of our commercially insured patients, or 10% of the profits we earn from those patients, that throws our payer mix even more out of balance and reduces our ability to continue to pay for those programs I talked about that are aimed at early detection of cancer and other diseases. We'll have that much less to invest in prenatal programs to help care for the mothers and babies in our communities. And if the commercially insured base of our payer mix erodes enough over time, we will find ourselves in the same situation as 10 other hospitals that have had to close their doors forever. And our community will not just lose the important health programs. We'll lose our emergency department and our labor and delivery units. Expectant mothers will have to be driven miles while every second counts. Those pediatric beds that keep sick babies and children alive and well will be lost forever. And the ASC will likely close as they won't have anyone who can help a patient condition requiring advanced emergency treatment, which also happens frequently in my hospital. If you look at other communities like Richland, Georgia, you'll hear that they tend to lose their community bank after the hospital closes. They'll lose their pharmacy, and patients will have to travel miles to get their prescriptions filled. And when the Georgia Department of Economic Development tries to bring a new company to the area, the first Google search of your town comes up with a closed hospital, you can rest assured your community will not be considered. So that's a little bit about the hospital finance and how Certificate of Need helps hospitals stay financially viable by helping prevent the loss of commercially insured patients. I appreciate the opportunity to speak with you this morning and welcome any questions you may have. Thank you.
Thank you, Chris. Do we have any questions or comments from the committee? Leader Beverly has one there.
Thank you very much, and I appreciate your presentation. And I want to get to a couple of points, and you guys know, look, as the leaders of the House Caucus, we have been talking about Medicaid expansion for a decade or more now. And the reality is the urgency of the now, it has to happen. And so as you're talking about this, my question to you is, how would expanding Medicaid in this moment help rural hospitals?
Thank you for your question, and I'll say the just off the cuff, very quick answer is, we see about 66% of our patients that come through our emergency center with without insurance or underinsured. That cost alone is over $180 million. We don't get paid for that. And most often, even the patients who have what we call underinsurance, they don't pay their co-insurances or their deductibles. So that piece alone would certainly help all of the hospitals across the state with that patient group. I understand and recognize there's challenges with moving forward with something like this, but it definitely would help offset the cost of care that we don't get reimbursed now. And, you know, with that said, we could certainly consider other alternatives.
Thank you.
Chairman Cooper.
I have a couple of questions. First of all, when you talk about not getting any payment for that, we do still have the Indigent Care Fund, which reimburses hospitals, right? That does make up some of that $180 million that you're, right?
Yes, and we received, I believe, $4.6 million for that.
Okay, and if you are really a low hospital with people that are below 10% of the population or something like, there is a extra fund for that if you apply for it.
And I believe that was $1.4 million.
So there are some ways that you are getting payment for some of that.
Yes, of all the funds that we've received for underinsured, self-pay, indigent care, I believe the total was around $13 million.
Okay, so, and I have a question about the charity care, just so we know what we're dealing with. It's my understanding that when you count the hours for charity care, when you make that report, is it still where if you say that a procedure cost or that the hospital bill is $30,000, that's what you would turn in, yet if you are getting insurance payment for that, they would pay you $10,000 for it. You turn in the $30,000 or the $20,000 different as part of your indigent care, right? You don't use what it actually costs plus 5% or something. You use the highly elevated cost. Is that correct?
So there's two different numbers. The $180 million is gross charges. The 76.9 is netted down to actual cost.
Okay, but when you do the indigent care form to prove your indigent care, you use the higher number, correct?
But there is a cost report that's along with that breaks that cost down.
Okay,
Yes.
but it reports. And I'd certainly, congratulate you on being apparently a well-run small hospital and getting that recognition, but it's just that it seems
That was not
like-
good recognition.
What?
It was not good recognition.
Okay, I guess both of you speak so softly, I didn't understand. You were pointed out as doing more?
Providing the most charity care in the country.
Okay, and they were saying that's a big negative.
That's correct.
Okay, I didn't, sorry.
My apologies.
Well,
I'll share the article with you.
Because it just sounded like that you were really serving your community and doing charity care, and I'm going.
We are.
Wow, great. They'd like to be paid for it. I just didn't get that part of it.
Yeah, thank you. Actually, following up on what she mentioned, do y'all have just a ballpark of what your charges are versus Medicare, as far as your what they call the charge master? Is it 4 times Medicare, 3, 2?
It's
5?
all across the board. It could be.
A range of what?
Some of them are 3, sometimes 8, depending on.
So the report that she's asking for may list that 8 times Medicare, which is supposedly at least the government thinks it's your cost. So you would turn in as charity care the 8 times or the 3 times figure. I think that was the question, was that it can be confusing to those of us who, even if we're in hospital finance. I do know there's a big difference in how a rural, at least my impression has been, a rural facility negotiating with a Blue Cross or a United, even if it's for the quarter of your patients that are that. How challenging is that different from a metro hospital, or especially a CHOA or a Northside or Piedmont? Are you able to stand alone, or is that really, I do know in deference to those, in particular Piedmont and now Wellstar, which has taken over or partnered with the state's medical college health system over in Augusta, but I know I just drove by Piedmont, Macon on the way down here, and some others. It does look like they might be, as nonprofits, expanding into areas of Georgia that don't have that 90% commercial insurance that you mentioned about North Metro. are they actually using some of their revenues in excess of expenses, profits in a nonprofit? Are they using it to kind of help hospitals in the rest of Georgia? I mean, I'm not I'm not here to tout their charitable initiatives, but it does seem like they're going across Georgia and spending that revenue in excess, that actually helping hospitals that, like the medical college hospital, couldn't stand alone. It couldn't negotiate well enough. Is that helping?
I think it's probably helping communities outside of mine. I haven't been approached by anyone who wanted to buy my hospital. I think it makes sense to buy hospitals where there's some source of profit, and that may not be always the case in all aspects, and I'm sure that there's some mission involved in that. I can't speak to that philosophy, but I will speak to the fact that we are insignificant to the payers. We don't matter, and
So it's tough to negotiate.
it's incredibly tough. And I mean, just to get a phone call back is impossible.
Last question on the charity care are a lot of those people what we call working poor? By the way, is underinsurance, does that include Medicaid or not? Or are you mainly talking about high deductible plans that people don't pay their deductible? Which is underinsured?
Mostly it's the patients who have, like yesterday I was dealing with a patient who has Aetna, which is great insurance, but he has a $25,000 deductible.
And then, of course, all the ACA plans, the standard is $2,500 deductible, and I think studies show people don't have $400.
Exactly.
So you don't get paid. That's the underinsurance. Could be an Obamacare plan.
That's correct.
But but you get zero because it's applied to deductible. Do you think, though, those working poor who are now, we did expand Medicaid in Georgia, now that we expanded it for everybody up to the federal poverty level, 100%, don't you think some of those working poor will now be eligible for Medicaid in Georgia? And that you'll take them off your completely uninsured list if they're working poor, or are you saying they make more? If they make more than 100%, they should be on an Affordable Care Act plan, right?
You know, I can't speak to that without doing a little more research. I can say that we have, you know, I work in the ER. I'm a CNA, and I transport patients, and I see the same patients that come every day, sometimes 3 times a day. Those folks aren't going to apply for insurance. They're not going to tell us their name. They're not going to get any sort of, you know, go online and apply for anything. They're not going to do that. And I see those patients come every day.
Well, I hope we can advise people that if they don't make the poverty level and they're working 20 hours a week, they're eligible for, I mean, I know Medicaid doesn't cover all your expenses, and it's not the panacea that's going to answer all your problems.
I would love to have a Medicaid on some of these patients.
Well, good. We need to help you figure out how to do that.
Thank you, Mr. Chairman. And I'm going to drill into this Medicaid conversation just a little bit more because I think there's some misinformation going on, and I want to be very clear. You said earlier that 87 cents, if you were to get Medicaid right now, it'd be 87 cents. Is that for that 87 cents per 100, $87 per 100? So on 180 million bucks, you're talking about 156 million dollars that would be coming to you. Is that correct? Did I understand that correct?
No, sir. So 180, just to clarify the questions of both the Chairman Cooper and Chairman Newton, 180 million is what we call gross charges. The 76.9 is a costed down, so that's actually what it costs us to provide that care.
Gotcha.
So I would take the 76.9 times about 87% and say this is somewhere around what we'll get.
Okay, so in that space, you're talking about 55 million bucks, as opposed to, and maybe a little bit more than that, as opposed to 13. That's a significant amount of money just if you just expanded Medicaid right now. That's number one. The second thing about this workforce requirement is it has been abysmal with people coming in, signing up for this program right now. It's been abysmal. You have, Medicaid unwinding, 67,000 kids lost their health care in June alone. July, another 60,000. And so we have a crisis on our hands right now because of the fact that we have not used common sense to expand health care. I'd ask you this question, sir. Should we make it something that regions decide whether they want, put it on a ballot, let people decide it? that the people decide whether they want to expand Medicaid or not. We don't have a solution if we have leadership currently that refuses to see the real problem that's going on, and putting lipstick on the pig still makes it a pig. I digress.
Cooper.
Leader Beverly, I think I'm misunderstanding. It's my understanding as we go through the process of reevaluating people on Medicaid, that they're not dropping anybody. There was a cutoff date, and then over the next 14 months, the department is looking at everybody, and even though the cutoff date was passed, that they won't be dropped until they have run the process. And you're telling me, I thought it was the same way on Peach Care.
No, it's unfortunately, Madam Chair, is a lot of these folk who've been kicked off. They may have moved out of different places, so the administration on it is not actually reaching the folk that they need to reach, and so they're at a crisis right now. As you know, 40,000 providers right now who have to sign up for Medicaid. 40,000 of a Friday. 40,000 providers on Medicaid haven't signed up yet. They have until Friday to do it. 40,000 providers. So you have a culmination of bad events happening. That Medicaid unwinding is a large part of it. Is just because people haven't been, the administration of the unwinding hadn't happened in a way in which it does. But we're over 150,000 kids right now who are not on Medicaid because of unwinding. And it
Okay.
is administrative.
Okay, I've been dealing with the department on that. I guess we just have a misunderstanding on the differences of it, but I will check on that. Thank you
Yep.
for bringing it forward.
Okay, other questions or comments? Yep. Mike. Steve Scott, go ahead.
Thank you for being here. If you would you just speak for a moment on the work that your hospital does or your team does just to qualify people who might not have insurance, the processes that you go through and the work that's done to establish an insurer for a payer or for a patient that comes to you in whatever capacity they may come, and the efforts that you've put in place just to find payment?
Sure. Yeah, so we have a whole team of people who come and meet with the patients and try to get the information necessary to help them find a source of funding. I think I've got 7 or 8 FTEs in that department that just tries to help. Most often the patients don't respond. They don't provide the information necessary for us to help them. They will not answer their phones. They will not provide adequate documentation for us to do the work for them to obtain that insurance.
Right. So you would characterize the success rate of that effort as being slim?
I would say it's probably one of the more useless expenses that I have.
Thank you.
Cameron.
Thank you.
That's right.
There you go.
Thank you. I'm hearing a lot about expanding Medicaid and on the provider side for provider revenues, but I've never seen any evidence in all my years of how Medicaid improves patient outcomes. I mean, it's better than not having no insurance, but it didn't, I've never seen where it improves outcomes. The company I work for, we had a Medicaid contract in Tennessee, and from 1994 to 2014 when I retired, like newborns, there was no change in improvement in newborn care. In fact, there was an increase with things like psychiatric treatment or as far as medicines, and they were like the #1 state in the country for dishing out this kind of things. It sounds nice, you want people to have care, but at the same time, that care doesn't necessarily mean they're improving the quality of the outcomes of their treatment. Thank you, Mr. Chairman.
Dr. Rice.
There's significant,
You turned off.
there's significant data that supports that people haven't, is it not on?
It'll light up when it does.
Don't mash the button.
Okay, don't mess with it. There's significant data that supports that people having access to care improves outcomes. And I think that if we begin to understand that Medicaid, in some instances, are having a way to pay for your care, will give people more access because people will seek care more readily if they feel that they're going to have some level of coverage. There are many patients who don't come for continuous care because they have no means to pay for it. And therefore, we end up with their care becoming emergent care versus a continuation of managing their disease processes, particularly chronic diseases, in a way that prevents them from becoming urgent. So whereas I definitely would like to see us have more opportunities for providing care to people and it being covered, Medicaid expansion is one opportunity, a way to do that. I think we need to make sure that when we say that a Medicaid expansion doesn't lead to improved quality, it is because that's sort of one moment in time. And what we're trying to say is, I hope what we're trying to understand is that we want to get people into a continuum of care, which decreases the chances of emergent care and better improvement in their chronic diseases, and also preventive measures that will end up with them not actually ever developing a chronic disease.
Yeah, and I would agree with that. I think many hospitals across the nation are faced with the same kind of patient populations that we see. Obviously, we have a little higher percentage of indigent in our communities, but we do it regardless of their ability to pay. So if the patient has Medicaid, or if they have commercial insurance, or if they have no insurance at all, in all of my clinics, all 40 locations across South Georgia, I still take care of those patients because it's my obligation and my responsibility. I think you would probably find the quality of care is probably about the same in communities like mine when they shift to a Medicaid program. However, the services that can be offered to other patients and really enrich the lives of those patients will change, I think, dramatically, because you can consider alternative funding sources and invest in other things that you wouldn't have had available in the current model.
Leader Beverly has one quick question.
Yeah, this is just a real quick statement because I think we should just clear up misinformation. The World Health Organization talks about the determinants of healthcare, and poor health outcomes are a result of not having insurance. Institute of Medicine, Center for Disease Control, Kaiser Family Foundation. I mean, there's a litany of people who say that having Medicaid helps you in poor outcomes, and you have access to care, quality of care, preventative services, financial strain, and social determinants of health are based on people having insurance. So there are multiple studies out there who suggest that. So I think that we should just set the record straight that it would help a bunch of folk in the state of Georgia.
Representative Hagan has a question.
Thank you, Mr. Chairman. Thank you so much for being here and for your presentation. I feel like we've kind of gone off into a different conversation than CON modernization here, so I wonder if we could just come back to what are your thoughts as a small community hospital, not-for-profit, on CON modernization specifically? And do you have any changes you'd recommend or that you'd like to see, or do you feel it should be left as is right?
You know, I'm a big fan of competition. I think it helps make things better in communities. I do think that it's important that as we assess competition, that competition is equal. And, you know, I'm all for bringing in whoever wants to come into my market and take patients and take care of the indigent and underinsured patients. So I'm okay with making changes to the CON rules. I think some of them are antiquated and need to be changed. I do think that we have to do that safely, and I think sometimes as a rural hospital in the state of Georgia, we're not really considered as part of the conversation because, like the payers, we're not really significant. So I would love to see CON changed safely, and hospitals like ours considered as part of those changes. I don't really think that CON should be covered the same way in all parts of the state. I think there's things that should be considered differently, but that's just me being selfish as a rural hospital. But
Last question from
No, I just
Representative
want to
Cooper.
sorry. I just want to reassure you, I chaired the first committee on the major CON changes, And rural hospitals were at the forefront of what we considered for that, and making sure that we did not hurt our rural hospitals. And I know that the speaker and the chairman also, I think the members on this committee at least have that and certainly in mind, that we know that they have to be treated differently and there are different circumstances. So I don't think you need to lose sleep over that.
Well, I appreciate that. And you guys being down here in South Georgia actually is a testament to that, so thank you.
Well, any other burning questions or comments from the committee? Thank you all for being here, and we appreciate the information, a lot of good information for us to think about and consider. And I think one thing that's pointed out, healthcare is a complex issue, and it's not a one-size-fits-all. There's differences in rural, difference in urban, in suburban areas, and this sort of thing. And the amount of the insurance mix in one part of the state is not the same as in other parts of the state. So thank you for your information. We appreciate y'all coming today and being with us.
Thank you for having me.
Thank you. Okay, next on our agenda, Pam Clayton, Georgia Healthcare Association.
Good morning, Mr. Chairman, committee members. Thank you for the opportunity to be here today. I greatly appreciate it. I have the privilege of supporting quality advancement and regulatory affairs for the Georgia Healthcare Association, and GHCA leadership and our membership appreciate the opportunity to provide comment on this important topic, and we appreciate the committee's deliberative approach in this process. We know it's challenging, and appreciate your commitment to certainly considering patients and beneficiaries first and foremost in the process. I did send along a issue brief just for your reference, and also please know that if there's additional information that you would like for us to share, we'll be happy to do that, to provide any supporting documentation. But we have a diverse membership that is comprised of skilled nursing centers, also known as nursing homes, assisted living, home and community-based providers, and ancillary and vendor service members. But I want to focus my comments today on the skilled nursing centers, as they are regulated by Certificate of Need. And our perspective is likely different from other provider settings affected by CON, those that have presented already this morning, which was really great presentations, thought-provoking, and I appreciated the opportunity just to hear. But as you just stated, as with most things, one size does not fit all. And so I think looking at it from both from a geographic standpoint, but also from a provider setting standpoint is incumbent as we think about what truly is needed to advance Georgia's health delivery system across the state. To provide context, there are 365 skilled nursing centers in Georgia that include about 40,366 licensed beds. 143 centers are designated as rural and 222 are urban, so there's certainly a greater concentration of beds in urban areas. And of course, we function within a fixed reimbursement structure, so with Medicaid making up about 73% of our payer mix, and we don't have the flexibility in rate setting. Presently, our occupancy rate is at about 79%. Pre-pandemic, we were closer to 85%, and that was pretty consistent. We dipped down into the 60s during the kind of the worst points of the pandemic, but we've seen a gradual uptick in occupancy, and we anticipate that that will continue and that we will reach pre-pandemic levels, but that's going to take some time, as evidenced kind of by the trend line thus far. But occupancy trends that we have seen before and that we see presently indicate that the current needs for skilled nursing beds are being met. So with 85% average occupancy pre-pandemic, we feel like that those occupancy needs are being met. While skilled nursing centers are a vital part of the healthcare continuum, and we're very proud of the care and service that our members provide, we also recognize Individuals prefer to remain at home as long as possible, or to reside in lower-level care settings, and so certainly that will impact referrals and transitions into the skilled nursing facility setting. Also, admission criteria for skilled nursing facilities is well defined, and while Georgia's aging population continues to grow, the current occupancy rates and the focus on ensuring that individuals receive the right care in the right setting at the right time indicate that probably the existing CO framework in terms of numbers of beds is working in the skilled nursing setting space. The ongoing focus on home and community-based services at the federal level suggests that those current occupancy trends will continue, because there is a significant focus and investment in home and community-based services at the federal level. Georgia has many rural skilled nursing centers. You just heard comment on the status of providing care in the rural setting across the state of Georgia, and oftentimes those rural nursing centers serve as the largest employer in the county. Admittedly, it's a delicate balance to ensure an efficient operational model in those rural settings, but it is necessary to ensure access to care across our great state, and the ability to operate and staff adequately in those existing centers, and to do that efficiently would be greatly affected if multiple centers opened in a given area. And we believe it's important that to serve folks where they live and where they want to be served. And so caution is needed to avoid those healthcare deserts as it relates to skilled nursing care. As Anna mentioned earlier, Georgia continues to grapple with a healthcare workforce crisis, just as the nation does. And we are struggling to meet the discharge needs of hospitals and other referral sources due to the workforce challenges. Just being very transparent. Disruption of the CON framework relative to increasing numbers of beds and locations across the state would likely affect that in a significant way. We lost approximately 6,000 employees during the pandemic, and we have not returned to pre-pandemic levels. In fact, our sector has been the slowest to recover when you compare employees and those migrations and returns as compared to other settings. New federal minimum staffing standards that were just passed, we're currently in the comment period related to those minimum staffing standards, are going to greatly exacerbate this crisis if they are implemented as written. And of course, that will be consuming a lot of our time and focus in the coming days. Not only will it cost billions of dollars to implement, CMS themselves put out a number of $4 billion, over $4 billion to implement, but the workers are just not there. That's probably the most pressing concern. So as we think about the healthcare continuum and kind of the delicate operational model, workforce is a big piece of the conversation. And then further, the trending of caregiver to consumer ratio is alarming. The numbers of caregivers compared to the consumers, numbers of consumers is really concerning. And often problems seem unending and solutions in short supply, and you were very clear to say that you wanted to hear about solutions, and I can appreciate that and don't envy the decisions you're tasked with making. And we want to be an active part of growth and innovation to ensure that Georgia's health delivery system excels. And so as such, we recommend that stakeholders, providers, and policymakers continue to focus on modernization of facilities, existing centers, innovation in care delivery, and workforce development, and certainly tort reform is significant to us as well. We are grateful for the legislation that has allowed for certified medication aids in skilled nursing centers and other initiatives that will help develop the pipeline and remove barriers to training and testing to help us shore up and ensure that we have adequate and competent workforce to meet the needs of Georgians. We have stood up a work group that is focused on the fair rental value system. and recommendations to incentivize investment in older facilities, and which would increase the number of private rooms, upgrade ventilation systems and other infrastructure, and that we think that's really important to be able to offer a service model in a setting that meets the expectations and the needs of Georgia's seniors and their families. So we hope that we can continue focus there and make some changes that would really make it easier to do some of that work that we want to do. In terms of care innovation, we are focused on technology and effective use of telehealth. And certainly we want to continue to expand that in a way that promotes quality outcomes, but also promotes efficiency. An investment in specialized service models is needed to ensure that we meet Georgians' comprehensive needs. The establishment of a unique rate for ventilator services that you all stood up in the past is a great model to consider for other specialized models of care such as behavioral and mental health that would be offered in the skilled nursing center, because oftentimes it's some of those referrals that are challenging to meet presently. It's difficult to ensure that we can meet the needs. So while the overall structure of the CON continues to be viable for skilled nursing facilities, and the current process allows for application if the unique needs of a population in a geographic region are not being met, a willingness to embrace enhancements to the existing certificate of need process if future demographic or special needs warrants is helpful. We've seen this work before. A great example of that flexibility in practice was when the 3-mile rule was changed that allowed to go beyond that 3-mile radius to build a new facility with the existing certificate of need. So I think to be, mindful and thinking about changes such as that really helps to ensure that Georgians can best be served in the counties and areas that they live in is definitely positive and something that should be a part of the discussion. So we thank you again for the opportunity to share our perspective, and I'm happy to take any questions, but just would conclude with saying that the overall framework for certificate of need is currently working for skilled nursing facilities relative to occupancy trends and what we project with the overall healthcare continuum. But certainly we want to be at the table and open to discussions and enhancements that would help us to modernize the service delivery and the settings that we offer that in, and ensure that we continue to be a great partner across the healthcare continuum. Thank you so much.
Thank you. Questions from the committee? Anybody? Dr. Newton.
Thank you for your presentation. The post-acute care space and the caregiving that goes on, many of us have seen it up close, and it is, please let your people know that we appreciate how they take care of our elderly that may have not many other options. I was curious about the average daily payment. You mentioned the 76% occupancy, but earlier, and I think Leader Beverly mentioned the backup that comes from EMS, holding a patient on the wall in an ER because there's no ER bed. There's no ER bed. I think GHA Anna mentioned that it's because there's no inpatient beds. There's no inpatient bed because they can't get somebody who is who's kind of maximized their inpatient benefit. Now they need to go to a post-acute care bed. And you've got 24% empty beds, but it's staffing, I'm assuming.
You're absolutely right. And so it just really highlights the challenges that we have because, we're certainly charged with, if we make that admission decision to admit someone to our setting, that we are able to meet their comprehensive needs. And quite honestly, staffing is the primary determinant right now. It's really about a numbers and a staff complement issue. And so
you mentioned that, there's Medicaid, which is the biggest payer, I
Yes,
suppose.
it is.
But there are commercial ones.
Yeah.
So on those two things, do you know what the average payment per day is for Medicaid? And who set, is the Fed set that, or is Georgia set that, or?
No, it is based upon, so Medicaid rate it's a cost-based system, and those rates are planned for each year based upon a cost-based system. And we're grateful that some investment has been made into the Medicaid rate in the last year plus, and very, very, very much needed. And then in terms of the Medicare rate, that is based upon a patient-driven payer mix. And so a model of based upon a standardized assessment, how they are coded, and so what their needs are, and so the payment rate is driven by that. Pretty low margin of Medicare on average across the state, and certainly much lower even on the commercial side.
You know, the two questions on that, though, are there delays in getting the commercial payers, which there are some or a significant number maybe of after a hip replacement or whatever,
Right.
that need 6 weeks of inpatient,
Sure.
skilled nursing facility. Is there anything we could do to speed up that process? Because the longer it takes, as far as I know, the hospitals aren't being reimbursed for that care or the custodial care really that's going on in a very expensive inpatient bed.
Yeah.
That's also holding up a patient that can't get seen in the emergency room or get out of the EMS stretcher. Is there anything we could do to expedite that with the commercial payers?
Yeah.
Managed care.
Yeah, and I appreciate that, because you're right, it is a challenge. Prior authorizations and then ongoing approvals to continue that stay is very challenging, and in our setting, they're just inundated with those authorizations and prior approvals. But I think that in the federal space, and I'm sure you're very aware and looking at this closely, there's a lot of attention right now on the managed care providers, and looking at just that issue of how much care is denied, what the delay is, and so we're very hopeful that that's going to have an impact. But I would say that there's nothing that takes the place at the local level of those hospitals and the post-acute care providers, the skilled nursing centers coming to the table together and say, real time, let's look at these challenges that we're experiencing and talk about how we can meet each other's needs, because to ensure those best outcomes, you don't need folks languishing in beds, and we need to be able to admit them into those beds that we have available, but we also need to be able to ensure that we are providing great quality of care and getting those outcomes that everyone wants, to avoid that bounce back to the hospital.
That's true too. Last thing, has there ever been any state who's done a provider fee like we did with the hospitals to allow us to raise the Medicaid rate, which might address your staffing challenges because everybody's needs a raise? So is there a provider fee going on now in Georgia?
Yes, there is.
Is there a way to expand it? Or are we already at the cap? Or do you know, or is that a thought?
No, there is a provider fee, and I can get that, the exact numbers to you on what that breakdown.
We're already at the cap. Okay.
Yeah.
So we're at
Yes.
the cap. Thanks.
All right.
Vice has a question.
Yes, I'm actually a little bit confused, and so,
Okay.
So, because you have a chart on here with demand versus supply, and then you have one on nursing home bed needs projection 2023 to 2030. And so, this is our presentation. That's the wrong presentation?
Yeah. That's
Oh, this is not your presentation,
Yeah.
okay, but that's why I'm confused, okay. All right, thank you.
all right. Yeah. So you should have a one-page
Okay,
issue
all right.
brief in your packet. Okay.
All right.
Pam,
Yes, sir.
thank you so much for being here. Would it be, and I resemble some of your remarks, because while we also are a health system with a few hospitals, I also operate a couple of skilled nursing facilities as well, care centers. Just to encapsulate the position that you have articulated, the structure CON for you works. As you look forward, you see workforce challenges that industry-wide, I think we all collectively see. Certainly within the industry that you're representing, you see that, and you see the challenge of providing care in a more modernized way as potentially an answer to help offset those workforce challenges, but that does not alleviate the workforce challenge. Saying that, CON reform really has no impact on that workforce challenge directly. It's an issue of supply and demand or the lack thereof.
That's right.
Correct?
Correct. Certainly if you have a new facility opens up just across the...
Creates that pressure for the supply.
Absolutely.
Thank
It
you.
exacerbates that stress. Yeah.
Very good.
Greatly.
Thank
And
you.
again, that operational model is very much
Understood.
challenged.
Any other questions or comments from the committee? Pam, would you, at the very beginning of your presentation, you gave us several numbers there. Would you go over that again, the number of facilities and the number of beds? I tried to write that down,
For sure.
I couldn't keep up
And-
with you.
Yeah, and I'll be happy to, again, send along that. But yeah, I was sharing that there are 365 skilled nursing facilities, and there's just over 40,000 licensed beds in total, 40,366. And just about, I need to find some bigger print somewhere. I can't read that PowerPoint. Yeah, so just about 19,000, I think, are in the rural setting. And about 27,000 in the urban. Yeah, 143 centers are designated as rural, 222 are urban. And again, very happy to send that information along to you all. Yeah.
Sharon Cooper has a quick
How,
question.
how many of those facilities have memory care, and how many beds are there for memory care? Since Alzheimer's is an increasing problem as people live to be in their high 80s.
Yeah, I can get the exact number that actually have a distinct memory care unit for you. I don't have that top of mind today, but that underscores the point that I was making around the specialized service models, because at times it's challenging if they don't have the appropriate physical plant and safeguards in place for someone with memory care issues or Alzheimer's to safely serve them in a setting. So again, as that number increases, we want to make sure that we can meet their needs, for sure.
Thank you very much.
Yep, thank you all so much.
Next, Deborah Stokes, Georgia Council on Aging.
Thank you, Chairman Parrish and committee members, for the opportunity to present to this special committee on CON modernization. I'm not going to go through the slide presentation, but it's in the packets for each of the members. As Executive Director of the Council, I have the honor to support the organization that since 1977 has served to provide access, information, and recommendations to the Governor, the General Assembly, and the agencies within the state government that have to do with issues pertaining to the aging population. So the affordability and accessibility of quality health care, housing, food, transportation, mental health services, broadband access for telemedicine, and caregiver support are all among our key areas of interest and concern to address the needs of Georgia's elderly. This mission brings us here to join the discussion about CON and how its modernization can potentially impact the delivery of quality long-term care to serve Georgia's elderly. For several years, one of the COAGE priorities has been to expand options for quality long-term care to serve Georgia's at-risk older adults. Shortly after the end of the 23 legislative session, former Council Chair Vicki Johnson began to research and review the landscape of how our current CON policies impact our state's nursing homes based on a supply and a demand perspective. This presentation is in your packet. Tara has been so kind as to present it. So Vicki can't be here today, but we fully understand that this is a very small piece of the CON modernization discussion, but it is still part of our mission to represent the interests of our aging population in this critical policy review. Vicki couldn't be here, but I hope you'll find her work in the information that's presented to be a good way to expand the discussion on nursing homes and CON. I'll give you a quick number of notable numbers to consider. In that packet, the information is listed that for 2025, the Department of Community Health projects nursing home bed deficits in 6 out of the 12 service regions. Currently, only 82% of nursing home CON beds are set up and staffed, and the state occupancy rate of its CON authorized beds is 68%. Yet, new CON applications are closed until occupancy rates reach 95%, despite projected regional bed deficits. In 2022, the highest occupancy rate, which was in Southeast Georgia, was 75%. This is information that we received from the department. Georgians aged 60 and older currently represent more than 15% of the state's total population. The senior population will expand by over 500,000 people between now and 2030. The projection is that by 2040, the number of Georgians who are 75 or older is expected to increase by 47%. So looking at this from a supply and demand perspective, unless we add long-term care supply, our unmet needs will also grow, and meeting that demand will become a challenge. Georgia wants to continue to improve the delivery of quality health care to all of its citizens, including the vulnerable, underserved populations. This can be achieved through implementing best practices, such as models focused on person-centered care, as well as adopting innovative reimbursement strategies to help pay for that care. So, as we are grateful for the opportunity to participate in this review, and we hope that our input sparks further discussions on modernization of skilled nursing facilities and across the complete continuum of care for older adults in Georgia. So thank you for your time, and as you review the information that's in your packets, we'll be happy to continue the discussion and provide any additional information or explanation of the information that's presented currently.
Thank you, Deborah. Any comments or questions from the committee? Dr. Newton?
Thank you for your presentation. I'm just looking on the one about I guess this is the current nursing home CON policy, is that it requires 95% occupancy before there's need.
Yes.
And it doesn't sound like, well, maybe isolated ones would have that, but in general, they're not going to have that.
They're not going to have 95%.
Is that 95% of their staffed ability? Like if they, okay, so it's the real bed capacity. And then the policy that could incentivize modernization is to loosen the certificate of need restrictions on building these innovative care models, facility modernization, things like, is that what you're saying?
Basically, so that the opportunity, for example, a skilled nursing facility in Cobb County, AG Rhodes, wanted to expand, modernize their existing facility. They did not increase the bed number, but because of the threshold for expenses being paid for it, they had to apply for another CON.
So do they have a capital max right now?
Yes.
And they couldn't do the expansion they wanted under the capital? Same thing we talked about with hospitals.
With hospitals, yes.
Which we've raised for hospitals, but it must still be low for nursing facilities.
For nursing homes,
Okay. Thank you.
I would like for anybody that would like to visit AG Roads to come and see the difference, but just applying for the CON because they wanted to spend more money to improve the situation for the people that live there, the application fee was $35,000. They're not equipped in dealing with, CON, certificate of need, and so they had to hire a consultant, and it took them a year to go through the process. just because they wanted to spend more on improving their facility. And you should see it. Many nursing homes still have 4 beds, not many, but some of them still have 4 patients to a room, and or 2. And these now at AG Roads will be single bedrooms for the people. They're more like you would want if you were aging, and more respectable people's individual needs and privacy. And that cost them a lot of money and a lot of time just because it exceeded the threshold. And they serve low income, and that's their target population.
Anyone else?
I'm an AG Roads fan.
Leader Beverly, go ahead.
Thank you. Just a quick question. On page 6, on nursing home bed need projections, and I'm not 27, I'm actually 55. I can't see those numbers. Can you give us a larger slide? Because I can't tell if it's 5,000 or 15,000 need in 23 on the bed deficit that we'll have.
Okay. I don't have that I don't have the same slide presentation.
It's 15,
So
okay.
I can't read it either.
Okay.
I have a smaller version
All
too.
right. All right, good. If we can get a copy of that, that'd be extremely
Absolutely.
helpful.
It's in your packet.
Okay.
Yeah. A larger copy?
Yeah, larger copy.
I guess if you're looking for a recommendation from the Council on Aging, it would be to maybe look at a modernization of the nursing home policies, how we actually address the nursing home policies, not even within CON, but in general, in terms of taking a look at how we can improve that segment of the healthcare continuum.
Okay. Thank you.
Representative Hagan has a question.
Thank you for sharing this information. Question, you have a 95% understanding that is very challenging. Do you have a recommendation on what that percentage should be?
We don't have a recommendation at this point, but we do feel it's a little high.
Okay,
We'd like to get more information on what the actuals are and have it based on that.
Yeah, Representative Hagan.
So to follow up on Cheryl's question here, I just want to make sure I understand this. So nursing home facilities cannot make a new CON application until their bed occupancy reaches 95%. But we just heard that because of workforce shortages, we're really not able to operate anywhere close to 95% in most cases. So unless or until we improve the workforce situation in this area, are you saying there's no way we could make anyone can make any new application?
It appears that way.
Okay,
Yes.
Thank you for clarifying that.
Rice.
Just like for us to connect the dots on the quality of care that is provided in either a skilled nursing setting or in a nursing home. And I don't know how that is tied to certificate of need. And so is there any tied to certificate of need and expectations or deliverable or quality of care that occurs in those two settings?
I can't answer that. In terms of quality of care that's required within those two settings?
Yeah, in order to, yes.
I can't answer that.
It's predominant in the licensure area?
Licensure and survey through licensure, predominantly not CON related.
Because if somebody, let's say if somebody wanted to expand, right? And their licensure and accreditation is taken into consideration, though, when they go to their certificate of need expansion or revision.
Can't answer it.
CON does not do that. Okay. The other point is that I think that as we see the modernization of healthcare and more care at home, I wonder if these projections will continue to hold. Because I think it's going to be challenging to ever meet a 95% bed occupancy threshold. Because more people are opting to create
Stay home.
solutions for care at home, either whether it's skilled nursing or for just an aging population. And of course, we have to consider also the variety of care that we need in a nursing home, so more beds for memory care and other things that we are seeing, just as we have a much older population that is aging in nursing homes. So they may not have major chronic diseases that we think of as traditional, but more memory care. And I haven't seen anything that really starts to talk about what's the diversity of the care beds that we need in those facilities. And I don't know if CON would take that into consideration, particularly when they're looking at expansion.
I think that's probably outside of the CON purview, but I do think that as our recommendation would be, that we should take a look at the modernization of the skilled nursing facilities and how they're operated within the state.
But see, we are a committee who's supposed to be looking at making
CON.
recommendations, so maybe we need to put it inside of the preview. I don't know.
Representative Cameron has a question.
Thank you for your testimony today. Isn't it true that nursing facilities go through a pretty rigorous process through CMS to be graded and periodically inspected, and those are published publicly?
Absolutely.
And you have to go through a lot. I mean, there's a lot of rigorous testing and the NCQ, I guess NCQ, some of those things fall into that. And you have to go through this, and if you don't, then everybody knows it. You know, they know where to go and where not to go.
That is true.
Thank you.
I agree. Thank you.
Deborah, thank you very much for
Thank
your
you.
presentation. We appreciate you being here. Okay. Next on our agenda will be the public comments. And we have several folks who have signed up who want to be heard, and we're going to get to all of you, but we'd like to ask you to be succinct and respect time so that we can finish our meeting on time. First on my list, Joseph Stubbs. If you would, please identify yourself, and we'll be glad to hear from you.
Good morning, and I want to thank Chairman Parrish and all the members of the study committee here for coming down to Southwest Georgia and hearing us and hearing a diversity of opinions here. My name is Joe Stubbs. I'm a board-certified internal medicine specialist since 1982. I've been in private practice in internal medicine for 41 years with Albany Internal Medicine here in Albany, Georgia. During that time, I've also served as president of the American College of Physicians, which is the largest specialty organization, numbering 161,000, and served as president of the National Medical Honor Society, Alpha Omega Alpha. I'm here today to strongly support competition in healthcare and repeal of the central planning process as reflected in Georgia's CON law. It was said several times how complex healthcare is in this day and age, but it's also true that healthcare is a very rapidly moving process, and nimbleness is going to be necessary in order to succeed in this healthcare process. While the complexity of healthcare causes a lot of problems that we see, CON law and its central planning process does not answer those needs. I speak from both a familiarity with national health policy regarding CON and, more importantly, from a local and personal perspective. My experience with the negative impact of CON largely centers on its use by Phoebe Putney Hospital, our regional hospital in Southwest Georgia, and its health system. There is no question in my mind that their use of CON has negatively impacted access to care, the quality of patient care, and health care costs in Southwest Georgia. In my opinion, Phoebe actually does better in the face of competition. When I arrived in Albany to start practicing medicine at Albany Internal Medicine, we were a two-hospital town with both Phoebe and the HCA-owned hospital Palmyra, which had started in 1971. To listen to administrators and board members at Phoebe, you would have thought that Palmyra posed an existential threat and was going to run this beloved community hospital right into the ground, taking all the paying patients and leaving Phoebe with just the poor, uninsured patients that would lead to its financial collapse. To the contrary, however, the competition at Palmyra spurred Phoebe to have an unprecedented growth in providing more services such as cardiac caths, cardiac bypass surgery, the state-of-art radiation therapy, state-of-art oncology service. And with this growth in services, Phoebe also saw unprecedented financial growth. Palmyra remained financially viable, but its attempts to add more services were stymied at every turn by Phoebe through the CON law. Palmyra's attempts to add OB, pediatrics, and cardiac catheterization were all blocked using the CON process, a process that at times appeared to have a lot of smoke and mirrors. Phoebe's use of CON was not the intended purpose of CON, which is to utilize expensive and limited medical resources more efficiently and thereby keep medical costs down. Their use was just the opposite, to maintain a monopoly on must-have services, so health plans would continue to have to pay more for those services in order to have those services be also forced to use Phoebe exclusively for all other services. And it is my opinion, and that of many policy experts, and that of the FTC, that CON is generally not used as a means of achieving better access to high-quality care at lower cost, but rather a lever to maintain a monopoly on services and keep the prices high, regardless of access and quality issues. And of course, those higher costs just spiral down to the consumer as healthcare companies simply pass those increased costs on down to private businesses and individual citizens in terms of higher premiums. The constraints of growth resulting from Phoebe's use of CON made Palmyra a prime target for a buyout, which is what Phoebe did in 2010. We now have a total monopoly of hospital services and many outpatient services. While Phoebe does provide many great and needed services, this buyout resulted in the community suffering a noticeable and palpable decline in the quality and access of care. The result, 16 to 24-hour waits in the emergency room and unnecessary transports of patients at Palmyra requiring surgery or diagnostic tests having to be transported to Phoebe for the procedure and then transported back when previously those services were well provided at Palmyra. Mammogram and CT scan reports not being sent to the ordering physicians. Discharge summaries went missing. Hospitalists failed to communicate with primary care physicians about their patient admissions and discharges. And 6 months delays for appointments in various specialties like psychiatry and neurology. The dissatisfaction with Phoebe among my patients has grown and is pretty pervasive. It seems every patient has a story of mishaps at Phoebe. One patient of mine recently was scheduled for a colonoscopy and had to go through that stressful prep that we all know about, only to arrive at the hospital for the procedure and be told that they had been canceling all elective procedures without patient notification due to lack of staffing. I had to literally beg another patient of mine whom I felt was on the verge of a heart attack to go to the hospital because he was so fearful of the quality of care he would receive. Today, practices such as mine are involved with value-based contracts with the government and commercial health insurance companies, where we seek to provide high-quality care at lower costs and with the hope of sharing in savings, but do so at financial risk if we fail. Hospitals and health systems have not embraced this concept. Private practice specialists with doctor-owned ambulatory surgical centers offer us a great opportunity to provide high-quality care, great patient satisfaction, and at a fraction of the cost. However, the personal costs of going through this CON process with health systems fighting you all the way and the limitations imposed by CON on the utilization of ambulatory centers have markedly diminished the availability and usability of such entities. The resistance I find among health system or hospital administrators in allowing the growth and perceived competition of ambulatory single or multi-specialty facilities seems flawed. They speak of, quote, lost leaders, end of quote, like ER, OB, primary care, and mental health, and the need to offset these necessary services that lose money with services like ortho, cardiology, and oncology that make money. Without these more lucrative services, they would quickly turn upside down financially and close the doors. I do not believe we have to say to patients that in order to have a viable hospital, you are going to have to put up with lack of choice, higher costs, lower quality, and lower patient satisfaction. I think we and our free market system are smarter than that. First of all, in states where CON has been repealed, hospitals are still thriving with businesses and positive financials. There will always be a need for hospitals to handle the more complex cases involving the services of ortho, cardiology, and oncology. And it will be the place where new devices and procedures will be developed and translated into our nexus of care. Secondly, hospitals need to embrace the concept of population health, where their financial goal is not just to see how many profitable services can be provided, but also looking at ways they can provide better quality of care at reduced costs within these so-called loss leaders. In doing so, these financially negative services could actually become sources of profit through shared savings. In summary, I firmly believe that whether we open up opportunities for competition or keep CON intact, hospitals and health systems will survive and thrive. But the quality of care, the cost of care, and patient satisfaction of care will be served most through competition and repeal of CON. Most states have already repealed or significantly modified CON to allow competition in health care, and their citizens have benefited. And I believe it's now time, it's Georgia's turn to do this for its citizens. Thank you.
Comments, questions from the Rice?
When you describe the closure of, or the change of Palmyra Hospital that I guess was purchased by Phoebe Putnam, and you spoke about, well, you inferred that there were certificate of need was used in order to limit Palmyra's ability to grow and diversify their service base. Was that more based on how the opposition rules are set up in CONs that they could delay or defer the opportunity for that CON application to advance?
Absolutely. I mean, there was so many obstacles and appeals and all kinds of structure. It was horrible. I mean, the need was clearly there, but opposition, I think, and as I said, there's smoke and mirrors in this process.
So are there suggestions that could be made for how we would look at that aspect of the CON process?
I think you need to look outside the CON process, is what I'm saying. I'm saying you need to look through licensure, Medicaid expansion, workforce issues. The CON is just a central planning that offers the opportunity to delay and slow down and create problems for healthcare innovation and development. So I don't believe, if you keep CON, I'm sure somebody's going to come up with some kind of amendment you can make to it, but I really think the answer really lies outside of CON.
Thank you. Scott.
Dr. Stubbs, thank you so much for being here. When was that CON contested? When was the filing of that? Was that recent or was that quite some time ago?
Well, it was quite some time ago, okay. Yes.
Okay. Let's go. Go ahead, Chairman.
I think that now that the hospital has opposition to the new hospital that they are trying to build or want to build in Leesburg. Is that not true?
I'll leave that to...
I believe it's true.
Yes, it's very true. But unfortunately, not unfortunately, FTC imposed a problem for the hospital that Phoebe, as a result of, they tried to get Phoebe to not be able to buy Palmyra. The FTC did. But Georgia's CON law usurped that. But FTC prevented Phoebe from actually opposing, through the CON process, any new hospital. What Phoebe did then was get the Dougherty County government to oppose it, and then that started the whole process.
I mean, I think that's one of, I'm sorry. I mean, and that's one of the problems that we have, is that the local hospital doesn't have to oppose something that's happening in their area. They can go out of their area and have another hospital do it for them, so that the hospital in the same area doesn't look like the bad guy. And I think somebody brought that up. I mean, the hospitals even were suggesting that we do something different, but I'm sure not opening it up to total, keeping one hospital from opposing the other.
Thank you for your time.
Thank you. Next, Price Core.
The hospital administrator.
Papers here from 2008, which was kind of the beginning of our struggle with CON, and your picture there from 15 years ago.
Oh, law.
Is in that front page. There's also a chronicle on the second page of the dates we've gone through. What happened to that jacket? References my talk. I gave this talk to myself last night, and I timed it at 4 minutes and 10 seconds, so I'll try to keep it at that. So, thank you, Chairman Parrish and other members of the House Subcommittee on CNN Reform and distinguished guests. First of all, I am Dr. Price Core. I am a general surgeon. I'm a specialist in general surgery, and I came back home to Albany, where I was born at Phoebe Putney in 1982, started solo practice, was solo for 4 years, and then joined my med school roommate, Dr. Chris Smith, and Dr. Gray Rawls, who had been in practice here for 30 years. Dr. Rawls was our mentor. He taught us a lot about the medicine of surgery and taught us a lot about how to take care of patients, not customers. He taught us that patients don't choose to be sick. Some like to be sick, but and that's another story, but they don't choose to be T-boned or have appendicitis or have colon cancer or breast cancer. But he also taught us don't ever let the dollar get too far ahead of the diagnosis. And that is something that's rung true with me. Dr. Smith and I had a vision of serving our community and building an ambulatory surgery center. So we built our first ASC, and we allowed Phoebe Putney to be the clerk of the works and help us oversee the building. Well, they saw what we were doing, and as they were building it with us, they were making plans to never let us initiate our process. They, along with the Alliance of Community Hospitals, began to add legislation or pork barrel a plan that would only allow single specialists to have ASCs. A podiatrist who's not a doctor of a DO or an MD could have a surgery center, but a general surgeon couldn't because a general surgeon was a multi-specialist. He was essentially a general practitioner. Well, what do you think about that? That's threat, and I think we were told we were multi-specialist, and even so finally we decided to play the game. We took it before the legislature, and we had a bill, and you remember this, Representative Cooper, we had a bill going on crossover day from one side to the other, and the Alliance of Community Hospitals said if you let general surgeons have ambulatory surgery centers because they touch multiple parts of the body, they'll be doing abortions all over the state. So they call me an abortionist. That's really not in my realm. If I were the kind of person to do an abortionist, which I'm not, that's more in the realm of a gynecologist. In one interchange that I had with a lawyer from DCH when we sued the Department of Community Health in 1999, the lawyer looked at me and was telling me that he could not recognize us as a single specialty, and I told him I went 5 years of specialty training, I took oral and written boards to be a medical specialist, and I was recognized by the American Board of Medical Specialties. And he looked at me and he said, we don't care who recognizes you. We're the state of Georgia, and we don't have to if we don't want to. Never been tempted to slap another man until that moment in my life. In 2015, we actually, as you'll see on your paper, in 2008, Senate Bill 433 was passed. And so in 2015, 7 years later, we finally built an ASC. But we built it with an LNR, which is a provision under CON law, but it limits us severely because it only allows for myself and my 3 partners to use it. It does not allow us to open it up to any other general surgeons. We offer outpatient surgery in a joint commission accredited environment. We offer colonoscopies, EGDs, gallbladders, breast surgery, and hernia repairs. We offer easy access to care and competitive lower cost to patients with increasingly higher deductibles in the insurance market we face today. We don't want to hurt our local hospitals. We want to attract people to our area. We're a rural area, and we want to provide services to those patients. There are certain services that we cannot provide in an outpatient setting, and we need our hospitals to back up. During COVID, I went to Mr. Scott Steiner, who's the CEO at Phoebe, and we offered to try to find some way to open up our surgery center to the surgeons at Phoebe so that we could work together. And it just didn't work out. We didn't have the manpower problems at our surgery center like Phoebe did, and you remember when we were inundated with COVID cases. We want to see CON reform to open up single specialty ASCs to other specialties so that the other patients can have a choice both personally and financially. Now, what about rural hospitals? Do all 159 counties in Georgia need their own individual hospital in today's environment? Well, with today's expensive healthcare delivery care being so high, it's very hard for an individual county in some of these smaller counties to have their own hospital. But could they have multi-specialty ASCs that are a joint venture with a community local hospital? Yeah, they could, and that might provide some specialty care to some of these people who don't have access to a major hospital or have difficulty with access to a major hospital. Competition's good. It lowers cost. CON designed some 30 years ago, as you see in my little brochure that I gave you. It has done just the opposite. As Dr. Stubbs mentioned, it's created monopolies to control healthcare costs. When we first opened, I knew what we charged for our colonoscopies. I cannot tell you how expensive a colonoscopy was at our local hospital. It's outrageous. But I noticed by comparing the explanation of benefits from spouses that I had done a colonoscopy on, that we had lowered the healthcare costs at our local hospital. They came down. Do we skim the cream off the crop? That's what everybody says about ambulatory surgery centers. But we have to do a certain amount of indigent care. And if we don't do a certain amount of indigent care over what our charges are, we have to pay a fine at the end of the year. So we have to monitor that very carefully. We do take Medicare and we do take Medicaid. And Medicare makes up about 40% of what we make, and 10% of that is Medicaid that we make. Amazing how many people don't know what certificate of need is. You sit here and you rule on certificate of need that affects every Georgian. But most people don't have no idea when you say CON reform or certificate of need. And I try to explain it to my patients, and they always say after I explain it, they go, well, no wonder healthcare costs are so high. I'm glad we don't have auto dealerships in our community that are under the same guidance. So you don't just have a Ford dealer, or you don't just have a Chevy dealer with a bunch of different delivery modules in town. A few years ago, the Wall Street Journal, Vail, Colorado, and Albany, Georgia, were the two highest care cost centers in the country. About the only thing we got in common with Vail, Colorado, particularly in the summertime. When I look at industry growth in my area, I cannot believe that healthcare costs have not certainly played a part in the retention of some of our industry and in the development and locating jobs in my rural area. I was just in Savannah last week watching that new auto plant go up. You know, we'd love to have stuff like that down here. But our healthcare costs have been one of the points, not the only, but been one of the points that has, I think, played a part in keeping us away from industry. So under the present CON law, we are prevented from affiliating with certain accredited care organizations like Privia because of the danger of losing our LNR. If we were to join up with an accountable accredited care organization, we could lose our ability to have that LNR, which is so restrictive to a single specialty surgery center. Well, why am I speaking to you? This is my last paragraph. I'm speaking to you for my patients, for my fellow physicians, and for myself, that we need CON reform. We need it to open up single specialty ASCs to become multi-specialty ASCs, just like North Carolina just did, by the way. We will accept abolishment of CON, but really we need to improve patient accessibility and lower healthcare costs by allowing us to open up our center to other specialties that can come in and provide lower cost accessible care.
From the committee.
I've got a comment.
Go ahead.
I really appreciate you speaking and coming today, but did you have to bring that picture? So.
I don't think you've changed a bit.
Just about 50 pounds lighter. That's when my husband was sick and I gained so much weight. But no, thank you for coming today. It is a problem, and I want to emphasize when we were discussing this in CON before. Is the brewery still here? The plant for the beer people? Is it gone?
No, Miller Brewery, yeah, Miller
Okay.
Brewery, which is now
Well,
Coors, which is.
At that point, they brought up the fact that they were not expanding because the healthcare costs were so expensive at the time. And there was another factory here which said that they weren't going to expand their facility to bring in more jobs for the community because the healthcare costs were so high. So what I just wanted to say, when you were bringing it up and the article was true, and it was, we talked to those companies when we were doing the CON before, and healthcare cost was one of the major problems.
The COE of Merck Chemical was a good friend of mine. He's now deceased. But he told me it wasn't the only reason they left Albany, but that the healthcare costs were very instrumental in why Merck Chemical shut down here.
Dr. Rice, you got a quick question?
So if this were to change and we would move it from being a single specialty, what other specialties would you bring into your ASC?
We could bring in ENT, otolaryngology, could particularly bring in gynecology. I'm independent, I'm private. I want my hospital to be the best hospital in the state. I served on the board for Mag Mutual Insurance Company, and every time I would go to Atlanta, they'd say, well, what's happening in Phoebe Putney today? And they wanted to hear some stuff. But I'd like to go up there and say, I come from Albany, Georgia, where we have Phoebe Putney Hospital, which is the best hospital in the state. But I am independent, and there are a lot of independent doctors in our area. We have independent otolaryngologists, we have independent gynecologists, we have some independent ophthalmologists. So we could bring in those other services and allow them to, again, work in our surgery center. Because we are Joint Commission accredited. We are very safe.
Ashley Daniel. Oh, okay, thank you. James Sams. Dr. Sams.
I want to thank the committee for being here and for your ear for a few minutes. I'm Jim Sams. I started my practice in internal medicine in Fayetteville, Georgia in 1982. I've been in single specialty and multi-specialty groups. I have been in private practice, and I have been in hospital employed groups. I have been a senior physician executive in a large hospital system and a executive in a health plan. The thing in my career that's given me the most pleasure, I'm the most proud of, is being CEO of a statewide medical group in Georgia comprised of private practice physicians who believe that the doctor-patient relationship should be at the center of the delivery system. And that's what holds us together. It's from this perspective, a statewide, this position that gave me a statewide perspective. Georgia's big. Georgia's the largest state east of the Mississippi River. And health care is very different depending on where you are in the state, but there are some very common themes. In support of my rural brothers and sisters, I will say, in my experience, there is more right in health care in rural Georgia than there necessarily is in our urban areas. So we have a lot to learn from our rural partners here at the table. If certificate of need's purpose was to control cost, it has been an abject failure. If the purpose of CON was to limit and restrict competition, it is a roaring success. We have seen hospitals use these monopoly powers to game the system. We see hospitals becoming hospital systems, and many hospital systems becoming what in fact look and act like cartels, capable of controlling and manipulating price, access, and choice with little accountability to the communities that they serve. Certificate of need has also bolstered and propped up the status quo. The status quo is unaffordable. The status quo is very brittle and fragile. As we all witnessed during the COVID pandemic, when we saw many of our hospitals and the delivery system as a whole near collapse. There's not a silver bullet. There's not a single solution for what needs to happen to health care in Georgia. Physicians certainly need to be part of the solution. We are part of the solution. We as physicians have a choice. We can be hospital-centric or patient-centric. We're not allowed to be both. Private practice physicians are uniquely positioned to be patient-centered. And yet, a vast amount of the regulations, laws, and rules prevent us from being able to come together in meaningful, relevant, and effective ways. And CON is one of those laws that prevents us from coming together. I think the way forward is with more competition. My parents were both general practitioners, started practice in Fayetteville in 1951. We were poor and rural at that point in time. For those of us who remember, Georgia tags had the county number, and then the rest of the tag number. When I was a boy, we started off at 114, so we were 114 out of 159. Many years, they were the only physicians in the community. They paved the roads, prosperity began to creep in, and as prosperity overtook us, new physicians came into town. And I asked my father, I said, well, you know, here's competition. What's this going to do? Is this going to be bad for us? He told me competition always did two things. It made him have to be a better doctor, and it made him busier. If Georgia is going to have a healthcare system that is equitable, just, and sustainable, it will be with more competition and the attendant innovation that goes along with that competition. I'm here to ask for repeal of the Certificate of Need.
Thank you, Doctor. Any questions or comments from the committee? Dr. Newton.
Dr. Sams, thank you for being here. And this kind of relates to the two of you that were just here. I know Dr. Kaur mentioned that ACO membership, accountable care organizations, which is part of the Affordable Care Act to try to get doctors who kind of understand the most about the prices, at least of anybody, when they send their patients. And you mentioned you have a national role or have had national roles. Are you aware that joining an ACO would violate the letter of non-reviewability or whatever the CON exemption was? And isn't that a huge thing that the federal government's trying to do, is to get physicians involved in looking at unnecessary costs in health care?
The federal government, and I'm not going to believe I'm going to say this, the federal government is the most innovative player in the healthcare space today because they have to be. If something can't go on forever, it won't. So the accountable care organizations, moving from shared savings to risk-based to physicians betting on themselves, being able to improve not only the care of their patients, but the health status of their communities, is a critical thing to have happen. Anything that gets in the way of us being able to come together in the right way, in relevant ways, to be part of the solution is a huge problem. My medical group can't partner with Dr. Kaur's surgical group because it will violate his LNR. So he stays on the outside. As we try to build physician networks across the state that offer choice and opportunity and real competition,
value, yeah.
Then you know we are at a distinct disadvantage.
Thank you.
Thank you for
Yes,
being
sir.
with us
Thank
today.
you.
Next on our list, Michael Harper. Michael Harper. Okay. W. Frank Wilson.
Good morning. Good morning.
Good morning.
I'm here as a citizen and as a 77-year-old survival of cancer, of asthma, and of COVID because Phoebe was available to me. It was immediate. I had good pre-care, in-care, and post-care service. Now, I am glad to be here with you instead of being referenced as the late Frank Wilson. Because by being here, I am an example of the kind of services that are available to us here in Albany, Georgia, Georgia County area, because of the existence of Phoebe and the care that it gives citizens. The one thing that I can say is that I did have the opportunity to have personal care with my doctors, both my oncologist doctor, both with the doctors who treat me with my asthma attack. I coded 3 times what they told me from the asthma attack. They called my family during the time of COVID and told them if I made it past Tuesday, of that Tuesday I would be a miracle. Well, you're looking at a miracle. And because of that miracle was made so because the existence of Phoebe, the immediate care. I didn't have to travel 2 hours for services. I was able to get to the hospital, get the services that I need, and like I said, here I am before you now being able to speak to you and having no one to speak about me. And for that reason, I would certainly support and continue the certificate of need because Phoebe does what it was created to do. And I'm open to any questions that you may have.
Good. Any questions or comments from Mr. Wilson?
Just glad that you're alive and that you got good care from your physicians.
I second that emotion.
Thank you, Mr. Wilson, for being with us. Shawnee Motley.
Good morning, Chairman Parrish and other committee members. My name is Shawnee Motley, and I serve as President and CEO for the United Way of Southwest Georgia. Serving 13 counties, United Way of Southwest Georgia mobilizes people and resources to improve quality of life and create sustainable, positive change in our community. That means ensuring that everyone has access to affordable and quality care. And Phoebe, under Scott Steiner's transformative leadership, does just that. Their 4,000 employees ensure the availability of adequate health care to meet the needs of all Southwest Georgians. So not just one county or the haves or the have-nots, but every single Southwest Georgian. And because of that, it's important that we safeguard against the unnecessary duplication of services that perpetuate the cost of healthcare services. Duplication of services takes away from building infrastructure and capacity when we're already battling here in South Georgia the notion of 2 Georgias. I'm originally Atlanta born, bred, and raised, and I've had the wonderful opportunity to serve here in Southwest Georgia for the past 8 years. And there are clear, distinct inequities and disinvestments in our community. So because of that, we must keep our community hospital vibrant and thriving. Secondly, Phoebe ensures that our local economy is thriving. They are a top employer across the region, and not only with the opposition of a certificate of need impact quality care, but it would jeopardize the economic boost that Phoebe provides the region through employment and building a pipeline of talent. I have been amazed by the innovations that have been created. I know Dr. Doug Patton with Augusta University was here earlier, and I don't know if you all have had the opportunity to visit their simulation center. It's one of the best and the most high-tech simulation labs in the Southeast. Lastly, because of Phoebe's infrastructure, they've been able to leverage key partnerships across multiple sectors, including our local educational systems, Albany Technical College, as well as Albany State, as well as our local school systems. I can personally attest to the power of that partnership how they've been able to look at innovative ways to get students excited about careers in the healthcare field and prevent brain drain, where I have heard in my 8 years that most young people want to leave Southwest Georgia, but because of the innovations that Phoebe has created, they are transforming and wanting to stay here. My own 17-year-old daughter is dually enrolled with Dougherty County School System, as well as our local college and career academy, where she is now a part of the Phoebe Healthcare Pathway. So currently, right now, she is at our Phoebe Main Hospital on the 4th floor, providing service as a certified nurse assistant. So she got her certification and graduated from Albany Technical College before graduating from high school. I have seen her blossom, and the trajectory of her future is so bright, and it's because of this partnership that Phoebe has allowed. We don't want to jeopardize that, because when you bring in multiple different hospitals in an area that cannot accommodate that level of capacity, you really risk these type of innovations in these programs. Additional partnerships exist between partners like Morehouse School of Medicine and Dr. Rice with the Elevation Project, with Mr. Sabs and opioid use and teenage pregnancy prevention, which United Way has been a partner with. So what's best for healthcare consumers in Southwest Georgia? It's Phoebe. We can't afford to compromise their infrastructure nor jeopardize the future growth of their programs and services. Being from Atlanta, I had to say this, Southwest Georgia can't live without Phoebe. Thank you. Any questions?
Any questions? Thank you very much. Appreciate you being here. That exhausts the list that I have. Is there anyone in the audience that has a burning desire to make a comment or two in the last 3 minutes we've got left? Well, having said that, then let me thank all of you for attending. Certainly want to thank our friends here at Albany Tech for hosting us today. I want to thank our fellow colleagues in the House and the Senate with us that attended this meeting today. This is the third meeting of 4. We'll be having our last meeting in Atlanta October the 10th, and would invite you to be with us at that time if you'd like. I want to thank our staff who do all the work to try to put all this together for us. They're here today, and we'll take a point of privilege and thank Tara for helping us out for these past years that she has. I've had the pleasure and honor to work with her, and she has done a terrific job. She's going to be leaving us this Friday, so this will be the last meeting that she'll be with us, but we want to say thank you, Tara. And we look forward to working with her in a new capacity and wish her well as she goes there. And for our new folks that are going to be trying to keep us straight, thank you all for being here. And Justin, thanks for helping us get done. And again, our friends here at Albany Tech could not have been nicer. Thank you all for being with us, and we'll adjourn our meeting at this time. Thank you.